Okay, I'm live, right? Okay, fine, thank you. Hi guys, I'm Dr. Marwah, and I think overthinking is real, doing is what really matters. So with these words, let's get started for today. The main focus would be to revise certain aspects of theory, and I'll also be discussing a couple of questions that were present in the test. They were deliberately twisted. They were looking easier, but when I'll discuss the answers, you will realize that lots of time the answers might be different from what you were anticipating. So let's begin with the relatively easier stuff. Quick comments in the chat box with respect to the audio and the visual components. And then we can start with the theory revision initially. And then subsequently, what I'll do is I'll be discussing those important questions with you as well. So I think everything is fine with respect to the audio visual part. And we are in a position to move on to the discussion. Yes, guys, hit the comment buttons. Let's see. Let me see the your passion for remembering the information. Carycomb's murmur kahan par milta hai? Condition where we get this, and it happens to be a mid-diastolic murmur. So the mnemonic to be remembered for these three mid-diastolic murmurs is CAM. That is C is for Carycomb's murmur, A is Austin Flint murmur, and then M would be for traditional mitral stenosis, for which the diagnosis part will also be discussed. But yes, at this moment, you guys can let me know for Carycomb's murmur initially, and then we can go ahead for the subsequent part. Carycomb's murmur is a feature of rheumatic carditis. Mark my words there, it is not indicative of any valvular lesion. It is just that the Ashkoff nodules are causing inflammation of the valves, because of which there would be a leakage of blood across the heart valves. And the query would be like, sir, if there's a leakage of blood across the heart valves from LV to LA, would it be a systolic murmur? No, the blood will leak in very minute amount from LV to LA, but then all of that will come back in the phase of diastole. So we have is a mid-diastolic murmur for Carycomb's. Then is this classical murmur Austin Flint, which has been asked so many times in your exam, where there is a presence of pistol short sounds. This would be a feature that is seen with valvular aortic regurgitation. And for mitral stenosis, actually, they have asked regarding two aspects, which I'll just highlight. One, they've asked regarding the special finding of the murmur of mitral stenosis, which is with respect to the pre-systolic accentuation that can occur. I mean, the murmur would be having a secondary spike. And second, they've asked in the last time's paper with respect to the severity of the murmur. And you are aware that the severity is inversely related to the S2 and the opening snap gap. So do remember these two important aspects, that mitral stenosis का murmur में दो peaks होते हैं. One is gonna be in the middle of diastole. Second is just before when atrial systole is happening. That's right before S1. And second is the inverse relation with S2 opening snap gap, जो कि धीरे धीरे कम हो जाएगा as the valve will keep on getting obstructed. So the first bit of information to be remembered is for mid-diastolic murmurs. The mnemonic is CAM right in front of you. The second aspect to be remembered for today evening is small sign would be seen in coughs restricting right heart. So this again, you know that C would be for constrictive pericarditis and not for cardiac tamponade. R would be for restrictive cardiomyopathy, and then would be right-sided heart failure. अब वो right-sided heart failure को inferior wall MI लिखें. He writes down right-sided heart failure as inferior wall MI or cor pulmonale. That is his hassle, but then you just need to remember that the C जो यहाँ पर है, that is not going to be cardiac tamponade. It is constrictive pericarditis, restrictive cardiomyopathy, and then right-sided heart failure is the second bit of information that you need to remember. Yes, guys, you can now comment on the chat box with respect to what is the condition that would be responsible for causing these large A waves in the JVP. A pretty straightforward one, has been repeated a couple of times, so I don't think so it should serve as any challenge for you. In fact, I want you guys to comment more than one correct option for this, because A waves in the JVP would be related to pressure changes with respect to the right side of the heart. And if there's any obstructive lesion in the right side of the heart, you would be having presence of large A waves. So I guess you guys would be spot on with respect to TS and PS, that is tricuspid and pulmonic stenosis. Logic simple सा है, रास्ता बंद है तो जोर ज़्यादा लगाना पड़ेगा. When you apply more force because of the physical obstruction, there is going to be large A waves that would be present. So TS and PS are two situations of large A waves, and then can be a pressure-based obstruction. What I mean by pressure-based obstruction is pulmonic artery hypertension. So I think in the previous, I can say 2 to 3 minutes, we've done 3 important bits of information that should be remembered by you. And well, why tricuspid stenosis is to be remembered is because of 2 primary reasons. इसमें जो P wave की height होती है वो भी बढ़ जाती है और A wave की height भी बढ़ जाती है. So when the P wave height will increase, we will call it P pulmonale. And in case the size of the A wave will increase, then we don't have any fancy terminology for it. We will simply be saying the word large A waves present here. So the message here is large A waves are seen with respect to obstructive lesions in the right side of the heart. So that is one, guys, that I wanted to say for large A. And now we'll migrate to the subsequent part of the discussion where we'll be speaking regarding condition where I would be having absent A waves present. Yeah. Okay. So let's focus on absent A waves. That would be with respect to atrial fibrillation, which is one of the commonest arrhythmias. And atrial fibrillation is again is asked is because of the 3 reasons. Pretty straightforward. इसमें ECG का जो फर्स्ट वेव होता है वो एब्सेंट होता है. P wave would be absent. A wave would also be absent, and you cannot ever have a fourth heart sound. Fourth heart sound क्या होता है? Atrial gallop rhythm that would not be seen with respect to atrial fibrillation. So negative sense में questions है. If you look at the information for TS, I said opposite. You know, both the A wave and the P wave are bigger. And for absent A waves, it would be absent P wave, absent A wave, and then the fourth heart sound would be absent. And yes, guys, I mean, you are hitting the right nerve for this particular topic. The most common sustained tachyarrhythmia in hypertension patients is atrial fibrillation. If I change it to geriatric population also, the answer will still remain the same. Whether it's a hypertension, whether it's a geriatric population, whether I, instead of geriatric population, say rheumatic heart disease with mitral stenosis, it would still remain atrial fibrillation. And one of the highlights of this condition would be a irregular pulse. So you guys are like spot on with respect to the irregular pulse in this patient. And yes, hit the comment button again with respect to condition where we get a what is irregular breathing. Like just I've told you irregular pulse. We have also theory with respect to yeah. Before we come on to the next one, guys, do answer my query. Irregular breathing will be seen in which condition? Yes, waiting for your inputs. Yeah, irregular breathing is gonna be answered by you as Biot's breathing. That's a feature of RAISE ICP. Very good, guys. Very good. I think Ashish, Zubair, everybody just picked it up spot on. I'll write it here only. Irregular breathing is what is called as Biot's breathing. And this would be a feature that is seen with respect to raised intracranial pressure. So a couple of closely worded terminologies which have been addressed at the moment. Now we move on to the next question. Canon A waves would be seen in. Canon A waves would be like super large A waves. They are also called as frog sign. And the condition where they would be seen is where the atria and ventricles are contracting together. Normally, it is the atria that contracts first and then is the ventricle. If the atria and ventricle will contract together, we call it AV dissociation. So yes, 2 conditions where we'll be getting it. One, there's a tachyarrhythmia. Second is a bradyarrhythmia. So heart rate se kar lena. Suppose he says that the heart rate of the patient is increased. There's palpitations experienced by the patient. So aap bologe that this would be ventricular tachycardia. On the other hand, if it says bradycardia present in a patient, then you will say complete heart block. As somebody answered very rightly, that complete heart block would also be called as a Stokes-Adams syndrome. So yeah, this is like a very spot on information with respect to atria and ventricles contracting together. That would be called as Canon A waves. So we've done 3 bits again: large, super large, and then absent A waves in a patient with some additional information put in. Then is that standard question of your paper, steep X and a absent Y descent in a patient. Somebody had commented about this CV wave also, that is for tricuspid regurgitation. So that's a accessory information. But then if it is gonna be hey, अभी तो LRR कर लो ना खत्म, अब रिवाइज करवा रहा हूँ तो we'll have to finish up the course in next about 2 to 3 hours. So X is yes and Y is a no for a lemonade. From lemonade, that the I mean the The rhyming word is for tamponade, right? Lemonade, tamponade, something is a similar rhyming here. And even the diagrammatic representation remains the same also. So you will say that cardiac tamponade is where a steep axona absent wide descent would be present. Cardiac tamponade can easily be picked up on the basis of Beck's triad, where you get muffled heart sounds, and along with muffled heart sounds, there's a hypotension and a non-pulsatile elevated JVP in a patient. This condition is also responsible for pulseless electrical activity because the heart is beating but the pulse is missing. The type of shock which is present here. What is the type of shock in cardiac tamponade, guys? Is it obstructive shock or is it cardiogenic shock? Obstructive versus cardiogenic shock. Quick answers, very good. Yep, cardiac tamponade would be a obstructive shock occurring in a patient, whereas when it comes to cardiogenic shock, that would be like post-MI, or it could be viral myocarditis that would be responsible for it. And then cardiac tamponade is where they would be impaired ventricular filling. So that is why we get an absent wide descent and a non-pulsatile elevated JVP. The ECG finding in this particular patient would always be low voltage. And to make it sound sophisticated in the question, he can also say the word electrical alternates. Whether he says low voltage ECG or whether he says electrical alternates, the concept is there's a lot of fluid outside the heart, squeezing the heart from outside. The intrapericardial space is more. So for echo, वो क्या लिखेगा? Diastolic collapse of the ventricles. For echocardiography, the report given here is diastolic collapse of the ventricles. That's again an important aspect, that the ventricles are not getting filled with blood, but instead of writing the word impaired Y descent, he can write the word diastolic collapse of ventricles, which is a good pickup point in a question. And as far as the treatment of this condition is concerned, if they give you a trauma case, where there is a hemopericardium occurring in a patient, then don't answer pericardiocentesis, like the guy was stabbed in the chest and the knife tip went into the ventricle. Then I'll not do a pericardiocentesis, because if I remove the blood, to or aa jayega, more blood will keep on coming. So in hemopericardioscentesis, we have to go for a thoracotomy. But if it is a medicine cause would be like a tuberculosis, or it can be lung cancer in a patient. So if we will give you situations with respect to malignant cardiac tamponade, or if he will say extrapulmonary tuberculosis in a patient, and then if he says that what will you do in a patient, then it is okay. We will be answering it as a echocardiographic guided pericardiocentesis. So like the JVP findings are pretty straightforward, guys, the ones that I've highlighted before you, and I think they're pretty easy to identify as well. Yes, I had very good attempts there. Let's move on to diseases of the outside of the heart. And what is the most specific ECG finding of acute pericarditis? Quick comments expected from you. 4 options present here. पेरिकार्डिटिस इन इंडिया विल मोस्ट ऑफ द टाइम भी लाइक अडल्ट्स में तो टीबी की वजह से हो सकता है, बच्चों में रोमैटिक हार्ट डिजीज की वजह से हो सकता है, or it can be a patient of chronic kidney disease, that is uremic pericarditis. And the fourth cause that they love to ask is Dressler syndrome in a patient. So if he says what is the most specific ECG finding in a patient, तो ST एलिवेशन में थोड़ा सा कंफ्यूजन हो सकता है ना किसी को भी कि कॉन्वेक्स है कि कॉन्केव है. द स्टाइलस ऑफ द ECG print out machine that can actually be becoming blunt, and because of that bluntness you may not be able to identify it. So the most specific finding would be answered as a PR segment depression. The basic logic is like this, that PR is going down and the ST part is going up in this particular patient. So there are 2 findings that I've highlighted before you. One is going to be the PR segment depression, and second is the ST segment elevation that is going up the baseline in this particular case. I'll just establish the baseline once again to align with both of them, the PR segment depression and the ST segment elevation. The correct answer for this one is option number C. Thoda sa PR segment depression is the specific finding that would be present. So TB, rheumatic, uremia, and Dressler syndrome are a couple of those options that I have currently mentioned before you. And most of the time they will ask you about treatment of Dressler syndrome. No, bache, the answer is not A. The specific answer is option number C for this one. Dressler का treatment बता दो. I think they've asked in the previous paper pathology में question था. It is autoimmunity. Yes, it is to be treated with NSAIDs, that is non-steroidal anti-inflammatory drugs that should be given. Most of the time we'll be giving aspirin to this particular condition. So though this is a autoimmune pericarditis, It is a late complication of myocardial infarction. 6 हफ्ते के बाद में होता है. The patient has been discharged, but then he'll come back with chest pain. The cardiac biomarkers would be normal, and there would be presence of ST segment elevation concave with the PR segment depression. So we'll be giving aspirin for management of this patient. Very good. I think people were very fast to comment with respect to the causes of important ones of acute pericarditis, and it would be cause specific treatment. Now, अगर इसका इलाज नहीं हुआ, if these patients are not treated, then what will happen? These patients will develop a complication. The complication would be in the form of a pericardial effusion. Hit the comment button. What is the normal fluid outside our heart? How much fluid is present outside the heart? I mean, more than how much will be called as pericardial effusion? Like outside our lungs, we have 20 to 50 ml. When it comes to fluid outside our heart, it would be 20 to 50, 50. So anything more than that would be called as a pericardial effusion. And the ECG finding in this case, as I've explained to you already, would be called as a low voltage ECG. And apart from low voltage ECG, because the heart is dancing in a bag of fluid, so he will use the word electrical alternance. That means there's a fluctuation in the voltage of the R wave. Now, when it comes to the chest X-ray findings, so you can see there is water outside the heart in this case. It looks like a case of apparent cardiomegaly. Like if you look at it, the heart looks very bigger. But when you look at the X-ray findings in a pericardial effusion, you would be having is a money bag appearance. And if the radiologist is money-minded, तो फिर वो money bag, तो मतलब they will be focusing on the word money bag only. ना पैसा चाहिए भाई सबको. But yeah, I mean that old school data is also there. That is the water bottle heart for this particular condition. So any of the two terminologies would help you in identifying that there is a pericardial effusion present in this condition. Hit the comment button. Investigation of choice for minimal pericardial effusion. Would you like to answer as X-ray, ultrasound, echocardiography, CT? I could have said MRI also, but then it's okay. चलो 4 में से बताओ. Yeah. We will be doing a echocardiography. हार्ट के लिए तो echocardiography ही करते हैं. पूरी कार्डियोलॉजी में 2 टाइम ही होता है जब वो CT chest देता है. In whole of cardiology, there is like 2 times when he will give you CT chest and a couple of times when you will answer cardiac MRI. तो कब कब CT chest आंसर करना है? In whole of cardiovascular system. In whole of cardiovascular system, CT chest should be answered. One for a person of constrictive pericarditis, CP, constrictive pericarditis, where there is calcification outside the heart, because CT is very very good for calcification. And the second condition जहाँ पे आप आंसर करोगे और constrictive pericarditis के सिवा, yes guys, hit the comment button. Which condition would you be answering CT chest? The hint is there is pain in the interscapular area. Interscapular area. मैंने हिट दे दिया, unequal pulses between the left and the radial artery, left and the right radial artery. Very good. That would be aortic dissection. There are only 2 MCQs in whole of cardiovascular system where you will be answering for constrictive pericarditis and aortic dissection. That's the critical part, guys. Aortic dissection में क्या होगा कि there would be a progression of tear involving the arch of the aorta. So therefore we can identify the tear using a very classical finding. उस क्या बोलते हैं उस finding को? Yes, guys. What is the finding of aortic dissection that we see? Very good. I think the more appropriate term would be a tennis ball appearance, no? It is a simple, it's a simple intimal flap, no? So that would be called as a tennis ball appearance. Like जो भी tennis का ball होता है, that has the scrimmage का ball जो हम खेलते थे ना cricket बचपन में, right? So cricket ball के पैसे तो होते नहीं थे, तो used to play cricket with that scrimmage का ball, right? That's basically the tennis ball appearance that is present in this case. And cardiac MRI कहाँ पे आंसर करते हैं? तो cardiac MRI is to be answered for all the cardiomyopathies. Though like I would also prefer to do a biopsy in the patient, but then biopsy is invasive. So patients will not agree for that. So instead of like going in for an endomyocardial biopsy, I can be going ahead with a cardiac MRI for patient for cardiomyopathy, and even for heart failure. If he says what is the imaging modality, it is a cardiac MRI which would be there. Yeah, Dr. Shakir, perfectly right. You'll be able to identify this. And Nikhil, you mentioned regarding that hockey stick sign. That hockey stick sign on an ECG, if you're talking about, that's for digoxin, right? And when it comes to restrictive cardiomyopathy, mainly we get चलो अब किसी ने बोला ही है तो जरा मुझे कमेंट करना. The patient is on echo is having a starry sky heart. The question for everybody is starry sky heart would be seen in what condition related to the cardiovascular system. Cardiac MRI can pick up anything related to structure issues, but we'll prefer echo there. Very good, very good. I'll just wait for a few more seconds. Yes, starry sky heart would be seen with respect to amyloidosis of the heart. That amyloidosis will contribute to restrictive cardiomyopathy in a patient. आप इंटीग्रेटेड वाला वीडियो सुनोगे ना मेरा और मैडम का ऑन द यूट्यूब, इट्स वेरी मच देयर. द स्टारी स्काई हार्ट वुड बी रिस्ट्रिक्टिव कार्डियोमायोपैथी ऑन द टॉपिक ऑफ अमाइलोडोसिस. नहीं नहीं भाई, निंजा स्टार नहीं होता है. It is not a ninja star. Starry sky heart on echocardiography. This is the speckled appearance that you see, and that's for restrictive cardiomyopathy, which is caused by amyloidosis. So a lot of like high, I would say, yield information on this particular slide. Each one of them are like questions that you should be knowing. And yeah, DCM is for ninja star. Yep. Okay. Moving subsequently, I have already explained to you for cardiac tamponade what are you supposed to pick up in a question. One is the finding of pulsus paradoxus, but question को pulsus paradoxus से solve मत करना, because pulsus paradoxus is also seen in question of constrictive pericarditis. So don't use pulsus paradoxus. Don't use pulsus paradoxus to solve the question of cardiac tamponade and constrictive pericarditis, क्योंकि दोनों में मिलता है. So what will you use is the blood pressure value. Crushing patient is gonna be cardiac tamponade, BP recordable is constrictive pericarditis, then is the JVP finding. यहाँ पे the JVP will be non-pulsatile, so there would be no rise of the JVP with inspiration. There is no Kussmaul sign present here. Kussmaul sign is absent with respect to patients of cardiac tamponade, but Kussmaul sign will always be seen in patients who are having constrictive pericarditis. तो आपने solve करना है pulse, blood pressure values and the JVP finding, but the JVP finding here is totally different from that of constrictive pericarditis. Similarly, don't use ECG in this condition, बिकॉज लो वोल्टेज ईसीजी तो पेरिकार्डियल एफ्यूजन में भी होता है, कार्डियक टैम्पोनाड में भी होता है, एंड सिमिलरली द मनी इन द बैग इज एनीवे प्रेजेंट इन बोथ पेरिकार्डियल एफ्यूजन एज वेल एज इन कार्डियक टैम्पोनाड. सो द मेन message is, I mean, what are the points to be looked for? Check the blood pressure values. Check out the non-pulsatile elevated JVP. Apart from the common findings, those that are not underlined are the common findings which are present, and the ones that are not underlined, like, I mean, they are not to be used for diagnosis in this condition. Pneumothorax and cardiac tamponade is okay. There's a question यहाँ पे मैं दिखाता हूँ आपको. आपने जो क्वेश्चन पूछा है मैं चलो उसको मेंशन कर देता हूँ, थोड़ा लेटर आना था. This was like a question that was put up to me कि सर अगर किसी पेशेंट को कार्डियक tamponade है and a person is having a pneumothorax, then first of all तो मैं आपके क्वेश्चन को rephrase करता हूँ that it would be tension pneumothorax versus cardiac tamponade that needs to be differentiated, and the main differentiating feature would be absent breath sounds. Na? In cardiac tamponade also the BP will be crashing. In tension pneumothorax also the BP will be crashing. But in cardiac tamponade, like you will be noticing JVP is elevated. Tension pneumothorax also the JVP is elevated. The main differentiation would be with respect to absent breath sounds and absent air entry. And apart from this, I can also say one more fact, mid-diastolic shift. The heart का जो position है change हो जाएगा ना. Tension pneumothorax में the heart position would remain the same with respect to cardiac tamponade in a patient. So absent air entry, absent breath sounds अगर कभी भी लिखा हो, absent air entry and absent breath sounds, if it is written in any question, that highlights that there is a pneumothorax, and the tension word is based on the crushing of blood pressure in a patient. And on this side it is muffled heart sound, but then as I said, muffled heart sound इतना reliable नहीं होता ना, because muffled तो ऐसे मैं मुंह पे हाथ रख लूँ थोड़ा आवाज कम हो जाएगा, so it might be sounding like normal, only a little lesser in intensity. So what we need to focus on here is gonna be the word absent air entry and absent breath sounds for differentiating with the two causes of obstructive shock that I have currently explained to you. Not exactly dextrocardia, because heart position may be displaced to the left also, no? Like the person got stabbed in the right, so heart will go more towards left. So it's not only the stab injury will occur to left and the heart will go to right. So the heart position would be not a very, very good way to identify this, especially with respect to the polytrauma cases that we get. So Tension pneumothorax is a wide bore needle in the fifth intercostal space, and last time's FMG exam there was no fifth intercostal space, so your answer would be second intercostal space. So it is like a tension pneumothorax treatment is wide bore needle followed by insertion of a chest tube that is 40 or 36 French gauze ka with the underwater seal drainage for management of tension pneumothorax in a patient. Yep. When will we give DC shock in patient? चलो अभी आगे आएगा DC shock कब देंगे उसको. तो आगे चलते हैं. Constrictive pericarditis. Constrictive pericarditis again is a question which was with respect to the calcification outside the heart of the patient, and then the most important pointer is यहाँ पे blood pressure crash नहीं करता है. You would be having that small sign. Remember we discussed that COPs restrict right heart, so the constrictive pericarditis part, and then is the common finding. ECG यहाँ पे भी calcification की वजह से low voltage ECG होगा, so that is not a discriminatory factor which is to be identified. And then yes, he can help you with cardiac catheterization. Hit the comment button, guys. Tracheal deviation always contralateral for pneumothorax, but that's not very reliable on an X-ray, as the radiology people will say, because in emergency the X-ray done is a AP view, and we need to go in for like a PA view for the patient. Yeah, the cardiac catheterization finding is a square root wave sign. Square root wave sign is the cardiac catheterization finding in this particular patient. And then more importantly, कुछ small breathing तो नहीं होता भाई यहाँ पे, कुछ small breathing नहीं होता है. And then is that auscultatory finding, that gold standard for constrictive pericarditis. I mean, what should be written in a question that you immediately know that it is a case of constrictive pericarditis is pretty straightforward information, guys. Pericardial shudder. Somebody did comment about it earlier, so I just reinforced that information. वो pericardial shudder लिखे, pericardial knock लिखे, pericardial shock, knock, whatever, it doesn't really matter. Pericardial shudder is the main auscultatory finding. तो बस भाई लगे रहना है, इसी तरीके से persist करते रहो, right with the information, and you will keep on, you will be able to identify things better. The cardiothoracic ratio in this condition is normal, and sometimes we may be able to see evidence of calcification in this condition. That calcification is better seen on a CT chest, so that's why I had already mentioned that CT chest would be given in this question. And यहाँ पे जो word है ना, that would be steep X and steep Y, और वहाँ पे होता है steep X and absent Y. आप steep X और absent Y याद कर लो, जो मैंने बोला था ना कि pay X, absent Y and a lemonade wala mnemonic. I'll just highlight that again once again before you, that the key thing that you need to pick up in the question for especially if he's gonna talk about constrictive pericarditis is that calcification outside the heart, as I highlighted, and then is the finding of steep X and absent Y, the JVP finding. Okay, I'll just show that superiorly. X yes, Y no for a lemonade, that's for cardiac tamponade, जिसमें steep X और absent Y होता है. अगर दोनों steep लिखा होगा तब आप बोलना constrictive pericarditis. Absent X and steep Y. Okay, tricuspid regurgitation ना CV wave हो गया ना वो तो बच्चे. Like निकुंज said कि सर absent X and steep Y. चलो इसको लिख लेते हैं, ठीक है. आप कमेंट करो व्हाट इज द ट्रीटमेंट ऑफ चॉइस फॉर कॉन्स्ट्रिक्टिव पेरिकार्डिटिस, और मैं ये परम्यूटेशन कॉम्बिनेशंस लिखता हूँ सो दैट यू गाइज आर एबल टू रिमेंबर दिस इंफॉर्मेशन बेटर. सो आई थिंक दो वी हैव कमेंटेड अबाउट इट. क्विक इनपुट्स इनटू steep X and steep Y, steep X and absent Y, and then is gonna be an absent X and a steep Y. That would be a CV wave in a nutshell, are the three standard questions that are asked, and they are like super easy. दोनों में steep है मतलब calcification, steep calcification, that's how you can remember it. If there's an absent Y तो filling ही नहीं हो रहा, because the filling will not happen in cardiac tamponade, and if it is absent X then atria is not able to relax properly because right ventricle blood is leaking into the right atria. That is gonna be tricuspid regurgitation. So this was like a query that was coming up कि सर तीनों का permutation combination क्या होगा. Super easy. Steep written two types, steep, then it is constriction. Steep two times, it is constrictive. If there's an absent Y मतलब filling नहीं हो रहा, that is tamponade, and if it is an absent X, that is tricuspid regurgitation. Okay, the treatment for this particular condition is pericardial stripping. तो थोड़ा देख लेना if he is asked you with respect to cardiac tamponade, or whether he has asked you to give your interpretation with respect to constrictive pericarditis. So yes, guys, moving to the question that you can see on the screen, I'll just zoom it in and enlarge it for your convenience. A patient is having a pulseless ventricular tachycardia. He says, what is the first step in the management of this patient? First step in the question is with respect to the first step in the management of this chap. So, okay, I can pick up a D, I can pick up a C, I can pick up a B there as well. No, if he's himself saying the word pulseless ventricular tachycardia, तो check pulse तो नहीं करेंगे, and we will not also be checking responsiveness of a pulseless patient because this is not a case of basic life support. So scene safety तो basic life support में करते हैं ना. If person is in intensive care unit, then we don't check the scene safety. This question has been repeated multiple times, so it is a simple straightforward start the CPR in the patient at a ratio of 30:2. The question is of advanced cardiac life support where you would be having manifestations related to specifically a pulseless ventricular tachycardia. And this is not PSVT paroxysmal. Even if it is PSVT, na, even then it is first to be answered as a vagal stimulation. This is a pulseless ventricular tachycardia, guys. Like somebody commented adenosine, so I hope it is clear to everybody कि हम PVT की बात कर रहे हैं. And therefore we have to start CPR in this patient at a ratio 30:2, which is what we casually called as code blue for this patient. इनफैक्ट अगर आप बेसिक लाइफ सपोर्ट की बात कर रहे हो वहाँ पे होता ना in basic life support it is verify scene safety, then is after scene safety it is check responsiveness and shout for help. So it is SRS there. SRS would stand for scene safety, then is responsiveness, then is shout for help. I mean any person who's done basic life support would come for management of this patient, and then what you will do is activate the emergency response. That is you will ask the person जो भी आपकी मदद के लिए आया, you will ask them to call 102, 108, or like in America they call 911. So it is arrange them in the correct order. So scene safety, responsiveness, shout for help, activate emergency response, that is calculate, call the emergency number, and then ask them to get the automated external defibrillator. Like I have said, at the Dubai airport, they've deployed drones to deploy the AED. Like the medical officer is sitting with a lot of TV screens in front of him. And if somebody collapses anywhere, like 100 boarding gates in Dubai airport, I think a lot of you would have traveled through that. So like you don't to physically run and get an AED if somebody is collapsing. The drone will get the AED at wherever the person will collapse in the shortest possible time frame. So you have to get the AED, that is automated external defibrillator. Now everybody comment in the chat box, what would you do yourself? Like you were talking to somebody to get the AED machine, you were also asking them to call at a helpline number to get the ambulance. Would you first check for pulse or would you look first for breathing? Yes guys, would you first check for pulse or would you check for breathing? Quick answers please. Waiting for your answers with respect to पहले क्या चेक करते हैं. Yes, you would be. अच्छा, pulse breathing आ रहा है. I think लिखा तो हुआ है यहाँ पे ना, look for no breathing. What the doctor will do is you will look at the chest movements of a patient and check the pulse simultaneously. So both are to be looked, but in the MCQ, if both are given, you will first follow whatever is written here. That is, look for no breathing or gasping and then check pulse simultaneously. And a doctor is supposed to not spend more than 10 seconds evaluating both of these activities. Now, if you have to give breaths to a patient, how many breaths would be given in 1 minute? Options are 4 breaths per minute, 6 breaths per minute, 8 breaths per minute, 10 breaths per minute. Hit the comment button. Let's see who comments first here. Okay, good. How many breaths would be given? 2, 4, okay, I'll increase it. 4, 6, 8, and 10 breaths. Hanji, great. But it is simple. It is 1 breath every 6 seconds. And 6 into 10 would be 60 seconds. So that would be 10 breaths per minute. The ratio is 30:2. वो तो ठीक है, 30:2 है. But then at the same time, guys, what you have to understand is 1 breath every 6 seconds is to be given to the patient. I think it's pretty straightforward. 1 breath every 6 seconds is to be given. So it would be at a rate of 10 breaths per minute. जो 30:2 है वो तो 15 seconds में करना है ना. जो 30s to 12 तो 15 seconds में करना है, then like you will be able to deliver anywhere in the range of 8 to 10. The target is 10 breaths per minute and 120 chest compressions. अब वो achieve नहीं होते हैं, that's a secondary issue. That is why we see a range. The range is 100 to 120 chest compressions in 1 minute, and then would be 8 to 10 breaths. But we have to answer a single value. Then answer is 120 and 10 breaths per minute is the target that we need to achieve. So I think I had good answers, and then once the AED machine will arrive, we will deliver a DC shock for the patient. So basic life support is pretty sorted. It is just simple steps which are to be followed. And here you will notice that the second step is check responsiveness, which is tap on the shoulder. But if somebody is collapsing in the intensive care unit, then you don't need to do this. So we'll be discussing regarding the management of ventricular tachycardia in the later part of the slide. But this, what you can see, is a AED. That is an automated external defibrillator. And yeah, this is what I was coming to, that in which intercostal space would you be placing the pad. Like this is the AED pad that is being placed. So kaun se intercostal space mein pad ko put kara jayega, that is the right pad is also to be put and the left pad is also to be put. So in which intercostal space would you be placing? You can see the position also related to the heart. So yeah, this would be the right second intercostal space. The site is right second intercostal space, parasternal line at the angle of Lewis is where we'll place the right paddle. And where would you be placing the left paddle in the patient? Very good. That is the second space. This left paddle, please. Left paddle and the site also. And the site also. Yeah, your answer would be 5th to the 6th intercostal space. Yes, and the line would be? The line would be? या एक्सिलरी लाइन, दिस वुड बी, अब वो एंटीरियर एक्सिलरी भी दे देगा है ना, पोस्टीरियर एक्सिलरी भी दे देगा, मिड एक्सिलरी भी दे देगा. सो इट वुड बी गोइंग इन द मिड एक्सिलरी line, and that's like, you know, the apex of the heart is about 2 centimeter medial to the mid clavicular. So these are the two pads that would be put, they're connected to the AED machine, and then that will help in delivery of DC shock of 200 joules biphasic. The AED machine fires the impulse standard. That will always be 200 joules biphasic, and that would help in termination of the tachyarrhythmia that the person might be experiencing. Now, if it comes to basic life support in contrast to advanced cardiac life support, in advanced cardiac life support, if he says what is the first step in management, this is what I was saying in the previous question also, whether it is pulseless ventricular tachycardia, ventricular fibrillation, we have to start CPR and we have to maintain bag and mask ventilation, attach the defibrillator. The objective of attaching the defibrillator is to decide whether it is shockable rhythm or it is a non-shockable rhythm. So if it is gonna be a flat line in the ECG, like the guy had an MI और उसके बाद में flat line हो गया, asystole हो गया, then we will not give DC shock to the patient. Then it is adrenaline that is being given along with first obviously CPR and then adrenaline that should be given. But adrenaline is to be given primarily in those circumstances bedside. That would be 10 ml of 10%. 10 ml of diluted 1:10,000 adrenaline that would be given to the patient. That is for the right hand side, epinephrine as soon as possible. But on the left hand side, they can be like a ventricular fibrillation happening that is twitching around the baseline, or it could be a broad QRS complexes for VT. If that is the case and the BP is unrecordable, then we can give total of 3 DC shocks to the patient. As you can see, this is DC shock number 1. Then is the DC shock number 2, and this is the DC shock number 3 in the patient. And no, it is not 3 shockable rhythms. It is like a total of 3 DC shocks that would be given for this particular guy on the left hand side, that is max. And every time after every DC shock, we give CPR because the rhythm will take some time to normalize. And we will also be using drugs like, yes, after the second shock, it is epinephrine. If he specifically mentions what is after epinephrine, you will say, I will intubate the patient. And this intubation has to be very precise. कौन से वाला नंबर का एंडोट्रेकियल ट्यूब डालोगे, बाय द वे, which number endotracheal tube would you put in adult patient, internal diameter? Yeah, the last DC shock is with respect to amiodarone, as somebody is commenting very rightly. So the person who asked, how do you treat a VT, right in front of you, man, we give DC shock, right? And after DC shock, we start CPR. And if it's not improving, then we have to give first epinephrine and then amiodarone. It's not vice versa. That is first amiodarone and epinephrine. It's first epinephrine, then amiodarone. Yeah, about 8 mm internal diameter chest tube would be putting in a patient so that we are able to manage the patient effectively. Okay, ROSC stands for return of spontaneous circulation. ROSC stands for return of spontaneous circulation. So good. Now we move on to like the must know rhythm disorders, pretty straightforward one. And here you will notice that the RR interval is varying. The number of boxes between R and R are changing. So this is one of the commonest arrhythmia with a irregular pulse. As you know, this is atrial fibrillation. And in those circumstances, since the first wave, the ECG, P wave is missing, so the boss is not there. And when the boss is not there, then the junior employees are making a mess of the situation. So there's the irregular pulse. Hit the comment button for the answer for the first one-liner that I put here. He mentioned regarding hypotension, the person had developed a syncopal episode, and he said, what is the management for this a patient with a irregular pulse and hypotension? Yep. No. If a person is having hypotension, it is recent onset and the person is having a syncope, then in those circumstances, like we need to give a DC shock to the person. For long standing, it is the race algorithm. But if the person will lose his consciousness and it's a recent onset atrial fibrillation, we can give a DC shock because the clots have not formed in the heart. But if he mentions the word long-standing atrial fibrillation with hypotension, like an alcoholic with cardiomyopathy, then if there's even an hypotension present, I will dare not give DC shock because there are clots in the heart. So there the answer would be given as rate control. Bas itna dekh lena, while answering these questions, aisa na ho ki he may mention that the patient is also an asthmatic, and if he says the word asthmatic, then I will not answer as asthma also. Hit the comment button, guys. If he says asthma in a patient, if he says COPD in a patient, then what drug would you be answering in those circumstances? Yeah, it is a holiday heart syndrome. Yep, I will be answering calcium channel blocker, that is non-dihydropyridine molecules, like I can be given diltiazem or verapamil for management of this patient. Now this patient, a long-standing atrial fibrillation. Yes, so you guys are right. We can use either verapamil or we can use diltiazem. So both of you are right. And because there is a tendency for clots present here to go into the brain and develop acute ischemic stroke, so I have to go for oral anticoagulation in this patient also. For the oral anticoagulation in this particular patient, that is valvular atrial fibrillation. For valvular atrial fibrillation, the answer is warfarin, bache. Apixaban is the answer for niche wala. And VAF, non-valvular atrial fibrillation. If he says the word valvular atrial fibrillation, मतलब India वाला condition ना. India वाला condition मतलब rheumatic heart disease with mitral stenosis is causing structural damage to the left atria. So we'll answer warfarin. But if it is a non-valvular condition, that's like alcohol-induced cardiomyopathy, then or hypertension-induced damage in the heart, then we'll be using apixaban for management of this patient. So pretty straightforward data. Like we have to anticoagulate, we have to go for rate control in these patients, and if required, we might even have to go for catheter ablation if there are recurrent atrial fibrillations. Okay, so let's hit the comment button, guys. If the case is having a recurrent atrial fibrillation and the patient is also having recurrent syncopal episodes, what is the best management? A person is having recurrent atrial fibrillation episodes, recurrent syncopal episodes are present in the guy. What treatment would you be recommending for this particular patient? Yep, ablation is a very good answer. Yeah, I think a better answer would be to deploy ICD, implantable cardioverter defibrillator, because I'm trying to say if an alcoholic is having a dilated cardiomyopathy, I would prefer to go for a cardiac transplantation if feasible. But that cardiac transplantation is not something which would be possible just like that. You need a beating heart donor for the same. So it's an implantable cardio. नहीं बच्चे pacemaker नहीं. It is like an implantable cardioverter defibrillator that is best for those recurrent episodes that are occurring in a patient. And yeah, there's another option that we can go ahead. That is, we can go in for a catheter ablation in these patients as well. But wherever like catheter ablation is again something that you need to do a mapping of the heart. So ICD would be a first answer followed by catheter ablation. And pacemaker is for the bradycardia component. Okay, so obviously not pacemaker. Moving to the next one. The ECG in this particular case is showing that classical sawtooth waves, because how am I calling that sawtooth is because they're not satisfying the height and the width criteria for the P waves and the T waves. Normally, like the T waves will be taller and the P wave will be chota. And here what you're noticing is that they would not be equal. So therefore, this would be a atrial flutter. And the highlight of atrial flutter is that we might have to give in this case a low intensity DC shock. Otherwise, the treatment of atrial flutter is same as that of atrial fibrillation. So I don't need to repeat the drugs there. The treatment algorithm would remain the same in this particular case. Now we come to the next arrhythmia, which would be seen in a young female, that is called as PSVT, that is paroxysmal supraventricular tachycardia. Or paroxysmal supraventricular tachycardia, what you get is narrow QRS complexes with a hidden P wave. If you look at the recording here, you will notice that there is no P and T separate. It's a single wave which is formed by the merging of the electrical activity of the P and the T. So this is a narrow QRS complex, a bit of ST segment depression also present, and then there is a single wave present. जो atrial flutter था उसमें तो कम से कम दो थे ना, उसमें तो ऊपर दो थे ना, there were at least two waves that you could see. It could be 3 also, it can be 4 also, but when it comes to PSVT in a patient, it is a single wave that would be present. Now PSVT, the name is paroxysmal. That means the attacks will occur suddenly, but if you do ECG when the attack is not happening, then ECG will be normal. If ECG will be normal in this patient, if ECG will be normal in this patient, तो फिर diagnosis के लिए क्या करते हैं, तो we will have to put a Holter in these patients, or we might have to put a loop recorder in patients of paroxysmal supraventricular tachycardia. I say this again, patients of PSVT, when they come to you, if they're not having an attack at that moment, they're not having palpitations, the ECG can be normal as well. So we need to use a Holter or a loop recorder to document our PSVT episode, and then based on the blood pressure values, we'll have to treat the patient. Like if the blood pressure is unrecordable, hit the comment button guys. If the blood pressure is unrecordable, or he says the word hemodynamic instability, or if the BP is less than 90/60, what is the first line management? Would you like to go for a vagal stimulation, adenosine, or a DC shock? Absolutely. Would you like to go for a synchronized DC shock or a non-synchronized DC shock? So you'll be saying that I'll select the sync mode of DC shock, which is called as cardioversion. तो यहाँ पे जो वर्ड होता है वो defibrillation नहीं होता है. यहाँ पे the word to be used is cardioversion if the BP is unrecordable, that is for any tachyarrhythmia. सभी में synchronized बोलना, सिर्फ दो ऐसे होते हैं जिनमें नॉन सिंक्रोनाइज बोलना होता है. यस गाइस, हिट द कमेंट बटन. नॉन सिंक्रोनाइज डीसी शॉक कौन कौन से एरिथमियाज में आंसर होता है? नॉन सिंक्रोनाइज डीसी शॉक का दूसरा नाम डिफिब्रिलेशन भी होता है. वैसे तो इंग्लिश से ही you will be able to solve it on basis of English only. Non-synchronized DC shock would be seen with respect to pulseless ventricular tachycardia, and the second one would be a ventricular fibrillation. Apart from this, all other tachyarrhythmias which given in a question, you will always say that, okay, I am gonna give a sync mode DC shock for this particular patient. So for PSVT, if the BP is crashing, it's a sync mode. But suppose in the question, the blood pressure values are given to be at least 90/60 or is more than 90/60, then you will go for vagal stimulation. Now, how do you go for vagal stimulation? You can go for carotid sinus massage, which I'll write as CSM. You can go for face ice pack. You can go for modified Valsalva maneuver. Any of the three can be given in a question. If you are having to select one, then carotid sinus massage would be a decent answer for adults. For children, it can be a face ice pack. So carotid sinus massage, face ice pack, and a modified Valsalva maneuver would be like a good one to go ahead here. And then subsequently, like what we are gonna do is give adenosine. Adenosine acts on which area of the heart to stop this arrhythmia? Yep. Adenosine will be acting on which receptor or which area of the heart to stop this arrhythmia? Yeah, that's okay. Adenosine will act on, yes, yep, it will act on the AV node. No, it will slow down, it will prolong the AV nodal conduction. No, the main thing is it will cause a prolongation of AV nodal delay. It will slow down the conduction, that's the re-entry circuit, and will be able to manage the patient effectively. So no, this would not be acting on the SA node. It is rather acting on the AB node and will help in controlling the arrhythmia. Adenosine is contraindicated in atrial fibrillation. We don't give adenosine to patients of atrial fibrillation or flutter. We give adenosine for patients only in PSVT, that is a paroxysmal supraventricular tachycardia. No, for prevention, if he says what is the best one, then our answer for prevention would be answered as catheter ablation. If a person is not willing for catheter ablation, then okay, I can go with verapamil for management of these patients. Yeah, catheter ablation is one of the best ways for management for prevention part. Now, if you look at the subsequent ECG, you will notice that very classical broad RS complexes with the Josephson sign present. So what we are talking about is a monomorphic ventricular tachycardia. This is a monomorphic VT because the size and the height of all of them is equal. And this is the drug where the keywords that would be given in the question would be a broad RS complex. is मतलब इतना broad है ना कि मतलब मिस ही नहीं हो सकता यार, इतना बड़ा ऊपर जा रहा है जो आ रहा है और जो नीचे आ रहा है ये वाला जिसको हम S बोलेंगे. So it is like broad RS complexes that would be present. So for the ectopic foci in a monomorphic ventricular tachycardia, adenosine तो AV node पे असर करता है ना. Here the problem is not in the AV node of the patient. The problem is lying in the ventricles. There is an abnormal focus. The focus is firing at 200 rates per minute. The abnormal focus could be firing at 250 times per minute. तो इस focus को suppress करना है. इस फोकस का जो इफेक्टिव रिफ्रैक्टरी पीरियड उसको इंक्रीज करना है. आप कार्डियक एक्शन पोटेंशियल पढ़ते हो ना, तो कार्डियक एक्शन पोटेंशियल में ऐसे ग्राफ बना होता है. This is the cardiac action potential. What I want to do is I want to increase the effective refractory period. If I increase the effective refractory period here, then I will decrease the excitability of the tissues. And yeah, the drug that I'll be using in this case for stable ventricular tachycardia is amiodarone. If it's not in the options, yeah, lignocaine as well, but the first answer would obviously be amiodarone. And for a pulseless ventricular tachycardia, we will be going ahead with the defibrillation for management. If he says the word himself pulseless VT, then it is a defibrillation that would be required. So amiodarone is the first line drug that would be recommended. If not in options, we can also use metoprolol for these patients. If not, then we can be using even lignocaine, but the first answer would be amiodarone followed by metoprolol. What do you mean by the word stable ventricular tachycardia is that in the question the systolic BP should be given to be more than 90/60. If it is less than that, then we'll assume the person is gonna go into a hemodynamic instability very soon. So VT is again something which is like standard arcs, and then he'll give you the cousin brother of ventricular tachycardia where we can be having the varying in the amplitude. If I say anything more, the answer in this case will also be seen. Epinephrine and amiodarone are in VFib and VTAC, adenosine and PSVT. That is perfectly right. Yeah, we will first say this is a case with respect to a polymorphic ventricular tachycardia, for which most of the time he would love to hear regarding the administration of magnesium sulfate. And in fact, most of the time he will ask you the causes for it. Two important electrolyte imbalances which can cause this are hypokalemia and hypomagnesemia. And then for the management of this condition, it is again the same. If the person is crushing, we'll go ahead with the defibrillation, but otherwise it is magnesium sulfate that would be required for management of these patients. Yeah, MgSO4. Okay, move to the next ECG and tell me the one that is currently shown here. Is it a VT? Is it a monomorphic VT? It's a polymorphic VT, or is it gonna be a ventricular fibrillation? Quick comments, guys. Yep, this would be a VFib. It's a ventricular fibrillation that is occurring because it is dancing all around the baseline. So this is a VFib that has been shown at the moment. And in this case, like the algorithm has already been discussed, that is those 3 DC shocks which have been covered initially. So that would be the tachyarrhythmias that are the core issues, and the pretty straightforward ones and easy ones that you basically need to recover or remember. And once we are sorted with these tachyarrhythmias, pretty straightforward ECGs that I have currently explained to you, what I'll do next is talk about some important CT scans which are relevant for the paper. So the first one that you can see here is showing that very classical star of death present here. And the moment you pick up that star of death in this particular case, you know that you're dealing with the case of subarachnoid hemorrhage. And even if they don't give the CT scan, they would be mention of nuchal rigidity in this case. There would be severe headache. There would be mention of worst headache of my life and stuff like that. Or he might even use the word classical thunderclap headache. Thunderclap headache से question मत solve करना. वर्स्ट हेडेक ऑफ माई लाइफ से क्वेश्चन मत सॉल्व करना, बिकॉज आपको मुझको भी हेडेक हो रहा है ना, तो यू एंड मी माइट ऑल्सो से अरे यार दिस हेडेक इज सो बैड, आई नेवर हैड इट सो बैड इन माई लाइफ. So what should be written in the question is that there should be nuchal rigidity along with headache. If you get a combo of the two, headache and nuchal rigidity, you are sorted for clinically saying it as a subrecurrent hemorrhage, and most of the time it is going to be trauma. लेकिन ये हमारा जो केस था वो तो she woke up with a headache, so she would be having a berry aneurysm at usually the ACOM location. But if he says where would you be having higher chances of rupture, that is at the PCOM location. And if he says what is the cranial nerve that would be involved in this case, then it is the oculomotor nerve that would be compressed by both unruptured as well as a ruptured berry aneurysm. The PCOM location is gonna be much more bigger in size, so that is why it's gonna be more prone to rupture in a patient. And both in ruptured and unruptured, it's the oculomotor nerve that would be involved. The investigation choice is CT scan. There can be two findings that can be given. One is the classical star of death, as I was discussing with you, but if it is not a star of death that is given, then he will always say the word blood in the sylvian fissure. And what you are expected to answer here is what is the next best investigation after a CT scan. Like I have already identified that this chap is having a bleed. Now what is to be done after this? No, we'll not go for a gadolinium enhanced investigation. It's a plain CT head for any brain hemorrhage. And if he says what is the next best investigation that we'll be doing in this case, yeah, we can go in for a digital subtraction angiography, but it is better that we go for an invasive cerebral angiography, because then we can in the same sitting fix the problem also, na? Because if I go in for a DSA then subsequently try and fix a patient, it doesn't make sense. So we take up the patient in a cath lab, do a invasive cerebral angiography, and once that angiography has been done, we will go for the treatment of choice of this condition, which you can see here that the treatment of choice in this condition would be answered as endovascular coiling. Another option that I have for management is aneurysmal clip, but considering shorter hospitalization stays, endovascular coiling would be preferred with respect to aneurysmal clip that can be deployed in this case. And then unfortunately, these patients can die because the feeder blood vessel can undergo a spasm. Na? The main blood vessel that is supplying the berry can unfortunately undergo a spasm and can cause death in this person. So if he says no. You will just say invasive cerebral angiography is the best way for diagnosis of this condition after a CT scan, because in the same sitting, you can fix it by going in for we can fix it by going in for endovascular coiling, where a platinum wire would be given to give structural support to the berry. Yeah, the most common cause of death is DCI, that is delayed cerebral ischemia. And therefore, if he says what is first to be done for management of this case, even before I take up the patient in the cath lab, what we can start in these patients by algorithm is nimodipine that will prevent this delayed cerebral ischemia in a person. The objective is to minimize the chances of, we will not give mannitol for these patients. It is nimodipine that would be used. And I'm not very sure, but this is what I heard. One of the students, FMG students, he was studying abroad, I think in Kazakhstan only. He had severe headache, and probably there was like a undiagnosed berry aneurysm that had ruptured. And following that, I think lumbar puncture was done, and that could have resulted in a cardiorespiratory arrest. Though later on, like that poor kid was put on antitubercular treatment as well at SMS Jaipur, but we lost him unfortunately. I mean, that was really sad. And like, I think the symptoms were matching more with respect to the headache component with vomiting, sudden onset. Though it's a speculation, I mean, I could not lay hand on the reports, but the way it looks like, this could be one of the possible theories there. Okay, first cause would be nimodipine. That's a calcium channel blocker would be used. This is going to prevent the development or delayed cerebral ischemia for this patient. No, we will start with nimodipine right away initially in these patients. Yeah, what about a 4-vessel angiography? That's a very good answer. We can go ahead with like a CT angiography, but then it will not help you in solving the problem. So if they give you a DSA 4-vessel angiography and then they say cerebral angiography, we would be more comfortable straight away in the cath lab going ahead with a cerebral angiography and fixing the berry in the same settings as well. Mannitol, no. like for the management perspective of this particular condition, it is like mainly the endovascular coiling, which is the primary treatment. Okay. It's only a software, right? I mean, cerebral DSA is like, I mean, if you go by digital subtraction, means the background vessels and the background brain tissue would be removed now, and only the brain blood vessels that would be seen. But देख के क्या करोगे? है ना, आप बेरी देख रहे हो, आप बेरी का मिरर बेरी देख रहे हो, लेकिन उसको देखने से क्या हो जाएगा? सेम सेटिंग में तो उसको क्लिप भी तो करना है या उसको कॉइल भी तो करना है. ओके. We don't give mannitol in these patients. Yeah, mannitol is only given for patients where there would be a impending brain herniation, and mannitol is not given in extradural hemorrhage. Mannitol is contraindicated in active CNS bleeding. Yeah, you can see the concavo-convex bleed in this case, very, very classical. So your answer would be pura bolna hai na. This is left, this is right, this is left, this is right. So you'll say this is right-sided. Then you will say acute because the bleed is white in color. And then you will say the person is having a right-sided acute subdural hemorrhage. And even if you look at the history here, it's very, very classical for an acute subdural hemorrhage because patient is presented with a weak in this particular case. And they're given a situation like this. Hit the comment button first and let me know what is the treatment for this condition. Options are burr hole and a craniotomy. Yeah, the source of bleeding would be cortical bridging veins. Cortical bridging veins. Yeah, lucid interval यहाँ पे भी लिखा है. Lucid interval is seen in both acute subdural hemorrhage. Lucid interval से question solve नहीं करना है ना. This is the commonest mistake that students do, that वो lucid interval पढ़ लेते हैं. I was waiting for this कि lucid interval पढ़ोगे. You guys did a great job by neglecting the word lucid interval, क्योंकि lucid interval दोनों में होता है. Lucid interval is seen in both extradural hemorrhage and it is also seen in cases of acute subdural hemorrhage. तो उससे क्वेश्चन सॉल्व नहीं करना है. हाँ जी, हाँ जी, हाँ जी. ओके, आई कैन गेट अ डीकम्प्रेसिव क्रेनिएक्टमी इन दिस पेशेंट. तो अब मैं ऑप्शन ही लिख देता हूँ बिकॉज मुझे बड़े सारे आंसर मिल रहे हैं यहाँ पे. तो एक तो है बर्र होल, एक है मैनिटॉल, एक है क्रेनियोटमी, सारे ही ले लो, ठीक है. और एक हो गया डीकम्प्रेसिव हेमी क्रेनिएक्टमी. तो अब कमेंट कर देना विच ऑफ द फॉलोइंग वुड बी यूज्ड फॉर मैनेजमेंट ऑफ दिस पेशेंट. और ये मत बोलना कि किसने बोला है, टेक्स्ट बुक का रेफरेंस के हिसाब से बात करेंगे. यस, व्हाट इज द फर्स्ट लाइन मैनेजमेंट फॉर दिस पेशेंट? बर्र होल, मैनिटॉल, क्रेनियोटमी एंड डीकम्प्रेसिव हेमिक्रेनिएक्टमी फॉर दिस पेशेंट. हाँ जी, हाँ जी. इसमें बर्र होल नहीं करते ना. बर्र होल से क्या हो जाएगा? ब्लीड तो ड्यूरामीटर के नीचे है ना. बर्र होल इज जस्ट अ टेम्परेरी मेजर एनीवे, सो बर्र होल तो होगा नहीं यहाँ पर. It is not mannitol which is used in this patient. Yeah, if there's a midline shift and there was a brain herniation, I'll go for burr hole. The main treatment for this patient would be a craniotomy. Decompressive hemicraniectomy कब करते हैं? फर्क क्या होता है दोनों में by the way? What is the difference between a craniotomy and a decompressive hemicraniectomy? हो गया ना, सर्जरी का तो डिस्कशन हो गया आई थिंक सो. So what's the difference guys? क्रेनियोटमी एंड डीकम्प्रेसिव हेमिक्रेनेक्टमी में डिफरेंस क्या है भाई? एक्यूट सबड्यूरल हैमरेज में क्रेनियोटमी है. बर्र होल इज आंसर फॉर क्रॉनिक सबड्यूरल हैमरेज. हाँ, क्रेनियोटमी में भी काटते हैं, क्रेनियोटमी में भी खोलते हैं ना. इन बोथ ऑफ देम वी रिमूव द स्कल बोन, राइट? अरे भाई भाई फंडे ठीक कर लो. डीकम्प्रेसिव हेमिक्रेनेक्टमी इज वेयर द बोन फ्लैप जो होता है उसको 1 वीक या 2 वीक के बाद में लगाएंगे. जैसे फॉर एग्जांपल दिल्ली पे बॉम्ब ब्लास्ट हुआ तो देयर वुड बी लॉट ऑफ विक्टिम्स who might have had a brain hemorrhage, and because of that brain hemorrhage brain में swelling हो जाएगी. So because of the swelling in the brain, that is called as malignant cerebral edema, we may not be able to close the bone flap immediately. So हम wait करेंगे कि 1 हफ्ता 2 हफ्ता का बाद में when the swelling in the brain will go down, that is when we are gonna go ahead and close the skull. So decompressive hemicraniectomy is done for those cases of malignant cerebral edema, that is bleed large हो से नहीं होता, सारे bleed बड़े होते हैं. It is decompressive hemicraniectomy is done for malignant cerebral edema. मैं example फिर से बोल रहा हूँ कि there was a bomb blast. Somebody was like 50 meter, 100 meter away from the bomb zone, so sharpnel injury did not occur. But because of the shock wave, the bomb, they can be like bleed in the brain. That can cause a lot of swelling as well. So the swelling will take some time to come down. Or in hemorrhagic stroke, they can be a malignant cerebral edema. and that can be treated with decompressive hemicraniectomy. But for burr hole surgery, according to the textbook, we will be going ahead with a craniotomy because dura ke niche the bleed is present, so the clot will have to be evacuated in this case. And burr hole tab karte hain jab there is gonna be a chronic subdural hemorrhage in a patient, which is gonna be the subsequent question. ये हर बार क्वेश्चन आता है, हर बार स्टूडेंट्स जो हैं इसके अलग अलग आंसर्स कर देते हैं, and I hope the concept is clear. Mannitol will not be helping in the treatment of, it's not the treatment of choice for this condition, right? And burr hole is a temporary measure. Chalo, the answer for this question is what I have explained to you, that is a cranial, हाँ burr hole ना EDH में करते हैं ना burr hole, तो अभी तो हम EDH तो पढ़ ही नहीं रहे ना, we are not studying burr hole at the moment. अभी करते हैं, अभी EDH भी आएगा, right? So there we'll do a burr hole is a temporary maneuver that can be done in either extradural or subdural hemorrhage. But अभी तो the main treatment is a craniotomy in this. ये भैया this is not an EDH. अभी तो इसको not a EDH. It is gonna be a subdural hemorrhage का केस है. Lucid interval पढ़ के EDH मत समझो इसको. This is not a case of EDH. That is SDH in a patient. चलो ये बताओ ये calcification कौन सी है ये वाली? What is this calcification in the middle, in the third ventricle, और ये इधर temporal horn में भी दिख रही है ना? So what is this calcification, by the way? Quick answers, guys. Yeah, this is the pineal gland. What you can see is the pineal gland which will have a calcification that is in the third ventricle, और जो साथ में है that is the choroid plexus का calcification that can occur in old age. Our patient is geriatric age group, no, 65 years of age. So in old people you can have a calcification in the temporal horns, that is in the the temporal horns of the brain can be showing some foci of calcification, that is mainly because of the old age group in the patient. So this would be a case of acute subdural hemorrhage. Now the next one that I can show you at the moment is where the area will appear black. It's on the right hand side, so I'll be saying this is right, this is chronic, and this is a subdural hemorrhage. Like Hrithik Roshan, he was shooting for that movie Crash. He underwent, he had a subdural hemorrhage of the chronic variety, and in right-sided chronic subdural hemorrhage, he says that it is a burr hole surgery that would be recommended. तो थोड़ा सा देख लेना इसको, burr hole emergency maneuver तो है, but then for right-sided chronic subdural hemorrhage, he just says that you just need to decompress, and the mortality rate in this condition will also be relatively higher. So these would be two specific answers that I've currently mentioned before you. Now comes that favorite question of yours, which is gonna be that biconvex lenticular hyperdensity. There is a lucid interval that is given in this question also. So the moment you read about the lucid lenticular hyperdensity, and he says क्या करोगे इसके लिए, तो comment कर देना guys, क्या करोगे. This is again a right sided, this is left, this is right. So this is a right extradural hemorrhage in a patient. We can call it extradural, we can call it a epidural hemorrhage. The source of bleeding in this case is the middle meningeal artery, and we need to fix it. Yeah, if it is a midline shift, we'll do a burr hole in a patient. That is okay, but that's not the treatment of the choice in this patient. Yeah, this can be idly also, but then the main treatment for this guy would be that we will have to evacuate the clot. So there would be a craniotomy. That burr hole to karte hi hai, right? That would be a temporary measure to buy some time. But if the bleed is as big as this, itna bada sa bleed hoga to burr hole se to kaam nahi chalega na. When burr hole is a temporary measure, that will not ease off the pressure in such a big bleed that is present. So only to, like, by time we do a burr hole surgery in a patient, so it is craniotomy with ligation of the bleeder. So in the MCQ, there would be only burr hole given. There would be a craniotomy that is described with ligation of the bleeder. So our primary answer would be a craniotomy with ligation of the bleeder, or decompression is what is recommended in this particular case. Okay, cool. Next is mannitol नहीं देते भाई. No, mannitol is not given in extradural hemorrhage. Mannitol is not first line here. This is a wrong answer that is being circulating in previous FMGE recalls. Mannitol is not given in case of extradural hemorrhage because the bleeding is stopping because of the tamponade effect. So if I will give mannitol to this patient, it will further increase the bleeding in a patient. So we will not be going ahead in this particular case. Yep. Okay. Now what you can see here is that woman who's having hypertension, and there is a intracerebral hemorrhage in this case. This is brain hemorrhage, as we casually call it, which occurs in the area of the putamen. And in this case, there is a weakness of the face and the arm and the leg. So the area of the brain that is involved in this particular case is the posterior limb of the internal capsule. Okay. Posterior limb of the internal capsule is where the bleed is present. And this will contribute to manifestations of a pure motor stroke. Yes, I think somebody commented the same thing. Pure motor stroke. It is a subcortical stroke which is occurring here. From the stroke localization perspective, pretty straightforward. No aphasia, no apraxia, no one of the A features that would be present here. And no, I'll not say MCA. It is the penetrating branches, na? यहाँ पे P वाला सब कुछ चलेगा ना. Posterior limb of the internal capsule, pure motor stroke, penetrating branches of the lenticulostriate artery. तो छोटी छोटी जो branches होती हैं, they are the one that will be affected. And if he says इसमें करेंगे क्या, तो there are a couple of aspects to be remembered. One is control the hypertensive crisis of this guy, and second would be control the raised intracranial pressure of this guy. तो hypertensive crisis के लिए जो दवाई देते हैं यहाँ पे, that would be answered as nicardipine. You'll use nicardipine, or you can be using labetalol. Target blood pressure बोलो कितना लेकर आना है? What should be the target BP in this patient, and by how much should you be reducing in the next about 1 to 2 hours? Yeah, target BP should be in the range of 140/90. उससे कम नहीं करना है बच्चे. Somebody commented lesser than that because that will decrease the brain perfusion. Na? Mean arterial pressure is a difference of, cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. So अगर मैं इसका MAP कम कर दूंगा तो उससे cerebral perfusion pressure भी कम हो जाएगा. So the target BP of this patient should be something in the range of 140/90. And then I said कि कितना कम करेंगे in the next next 1 to 2 hours में. The mean arterial pressure of this patient should be reduced by usually less than 25%, or approximately up to a range of 25%. I can say MAP reduction, mean arterial pressure to be reduced by in a range of about 25%. And the target is to achieve 140/90 for hypertensive crisis to prevent the rebleeding in this guy. And if he says इसका raise ICP कैसे control करेंगे, तो again answer mannitol नहीं है ना. Then we will say ventriculostomy in this patient. It is ventriculostomy or a decompressive hemicraniectomy. When to operate? Yeah, if the blood pressure in the brain is not coming down with ventriculostomy, if the ICP of the patient is still, or if the bleed is present in the area of the cerebellum, that is something in the range of like a more than 4 centimeter hematoma with respect to the cerebellum, that is where we go for a surgery in a patient. That is decompressive hemicraniectomy. The rationale is when to operate is only when the pressure will not come down by using ventriculostomy in this patient. So only when like ventriculostomy may, because you can see on the monitor na, what is the pressure. If it persistently remains elevated, only then a decompressive hemicraniectomy is to be done. That is to mainly reduce the chances of brain herniation in this patient. So okay. Yeah, somebody posted that previous NEET PG question, what is to be done in this patient? Next best step is answer is cerebral angiography. That V3F, you posted that NEET PG question, and he says what would be done next in the patient. So answer is cerebral angiography for management. I will not lower the BP. Why? Because if I lower the BP, the brain perfusion would be reduced now. So for person of subrectal hemorrhage, we don't try to lower the blood pressure. And nimodipine anyway does not cause lowering of blood pressure, right? It is for preventing a vasospasm. So cerebral angiography would be answered. IVH is an extension of intraparenchymal hemorrhage. Nimodipine would be something, okay, why not nimodipine? Because delayed cerebral ischemia develops over 48 hours. DCI occurs over 48 hours. No? It is a cause for, the word is delayed. So vasospasm will take some time to max out. So first we'll do a cerebral angiography in the patient. Chalo ji, fine. So I think we had a good discussion with respect to the type of CNS bleeds this is present. And let's look at these couple of questions. Patient is having neutrophils present, sugar of 40. Yes. He says, what will you do for this particular case? So there is like triadomeningitis present, and then we'll be giving ceftriaxone and vancomycin for management of this patient. For the question that came up in today's test, the answer was yes. Can you let me know the answer for today's question, guys? Quick answers for the question that came today. Okay, what I'll do is, give me a second. I'll just try to incorporate that file in my discussion also, so that I can just discuss the question that came in today. So you just need to give me like 30 seconds. I'll just disconnect my slide and come back again. And meanwhile, like, we can continue our chit chat. You have any doubts in between, so you can ask me. And I'll just be back with the question that came in today's test, because the chat was like, the question was simple, or the question was very easy to solve. So I thought I should just quickly mention regarding this question that came in today's paper. Fine, give me a sec, and the screen is gonna come back. Come on. Yes. Coming back in a few seconds. Yep. Okay, G. So this is a question that was present in today's pulse test, and I would expect answers from you guys. Pretty close values, I think. So I just wanted to see your responses, and we'll go back to the theory part in a minute. Like, headache is there, fever is there, altered sensorium is there in a patient, and then he is also mentioning digoxin-induced VT in a patient. Why amiodarone? No, for digoxin-induced, we go for lignocaine for the patient. Okay, so I am having various answers there. There is 80% lymphocytes, 20% neutrophils present. Look at the sugar, man. The sugar value will be, CSF sugar is 70, right? The CSF sugar in this patient is 70, and the blood sugar of this patient is 100. So the ratio here is 0.7, na? And the CSF sugar should be low in tubercular meningitis. Yes. Right. This is not एक दिन का हिस्ट्री पे टीबी कैसे हो जाएगा? वन डे के हिस्ट्री पे टीबी थोड़ी ना बोलेंगे. Guys, this is not tubercular meningitis. This is not tubercular meningitis. The CSF sugar is normal, and there is a 1 day history with altered sensorium in a patient, and there is no nuchal rigidity. Very good, guys. There is no nuchal rigidity. The answer to this question is option number A. That is a viral encephalitis in this case, because the first thing wo bola ki there is no nuchal rigidity in the patient. So yeah, this is viral encephalitis, guys. People are saying कि जी बड़ा आसान था and it was such a easy question paper. तो भाई ये क्वेश्चन तो गलत नहीं होना चाहिए ना. So I just wanted to point out, yeah, now like a lot of guys have come up with the correct answer in this particular case. It's a 1 day history, so it can't be TB. And bacterial meningitis will require neutrophils in a patient. So right in front of you, भाई जो आपको लग रहा है आंसर होगा, that will not turn out to be the answer for the one. तो यही तो समझा रहा हूँ कि डोंट लुक एट ओनली लिम्फोसाइट्स, लुक एट द क्लिनिकल हिस्ट्री ऑल्सो टू बी इवेल्युएटेड ना. ओनली लिम्फोसाइट नहीं देखते ना, लिम्फोसाइट विद शुगर देखना होता है. एंड द प्रोटीन्स आर ऑल्सो टू बी इवेल्युएटेड. तो प्रोटीन भी कोई बहुत ज़्यादा थोड़ी ना, 90 तो है. तो टीबी में तो ग्राम्स में बोला ना, टीबी इज गोना बी इन ग्राम्स. सो आई मीन द आंसर कैन नॉट बी द आंसर टू दिस वन, एज यू कैन सी फॉर दिस पर्टिकुलर पेशेंट इज The answer to this question is not TB meningitis, it is viral encephalitis. तो क्वेश्चन पेपर में भी यही होगा यार, तो थोड़ा सा ध्यान से करो. You guys are brilliant chaps, you know, बस वो थोड़ा सा यही रहता है कि इवैल्यूएशन करना. चलो एक और करते हैं. What is correct about the diagnosis of mitral stenosis who has come for an antenatal checkup? How to differentiate? Findings will be same, na? The nuchal rigidity part would be different. Nuchal rigidity is seen only in viral meningitis, and nuchal rigidity is not present in encephalitis in a patient. Yes, guys. Yeah. हाँ जी. This is a pretty straightforward one, na? Diagnosis पूछा, severity नहीं पूछा. This S2 opening snap gap, this is related to the severity. This S2 opening slab gap is related to the severity, and the diagnosis in this particular case will turn out to be like a loud S1 with a mid-diastolic murmur with a pre-systolic accentuation in a patient. Chalo, let's straightforward one. This is an easy one. Chalo, next one करते हैं. Anemia, leukoanikia. Waiting for your answers here. Then we go back to the theory component. Very good. Very good. I think most guys are getting it very correct. Leukoonychia is present in this case. Leukoonychia implies that there would be white nails present there. It is not a coileonychia, bhai. This is a leukoonychia present. There is a macrocytic anemia. Macrocytic anemia is a feature that is seen with cirrhosis, no? Macrocytic anemia can be seen with cirrhosis, and white nails can also be seen with cirrhosis, and there's an enlarged spleen in this case. No, बच्चे, this is not Plummer-Vinson syndrome. आप इमेजिन कर रहे हो कि क्वेश्चन में कॉइलियोनिकिया लिखा हुआ है, कहीं लिखा है कहीं पे कॉइलियोनिकिया, स्पून शेपर्ड नेल्स लिखा है. Is there an iron deficiency anemia given in a question? No, our mind is playing tricks. We are assuming that this could be a possibility. That is A, that is portal hypertension. The answer to this question is option number A. And our mind starts assuming that it can be coileonychia. तो मैं मतलब तीन में से देखो ना, मैं a lot of you got this correct also, so full credit to you. But what I'm trying to say is, out of the three, you will notice that like two were like which were looking super easy, and then they turn out to be a some have not attended. Okay, चलो मैं example दे रहा था. And most common complication would be a portal hypertension in a patient. Chalo, fine, ji, fine. So let's go back to our discussion that we were having, and let's focus on the next question. HIV positive patient presents with fever and vomiting. Vomiting episodes for past 3 days, and then you notice nuchal rigidity. There's an opening pressure with the lymphocytic pleocytosis. Treatment to be given would be, yep, that is liposomal amphotericin B with 5-flucytosine. So some questions which are from, like, reason I discuss them is जो पिछले साल वाले हैं, they will look super easy for you. These ones are like previous year questions, so you're super easy. But the moment there is a slight change in the options, you need to. That is why तो what TNE में तो I've been doing that only, ना, that we are trying to make you evaluate the options very clearly. Chalo ji. So everybody knows for acute bacterial meningitis there would be more than 1000 neutrophils present. The sugar will be less, the proteins would be elevated, the pressure will be more, and it would be turbid CSF or it would be cloudy CSF in a patient. For TB meningitis, I'll say once again, it is lymphocytes to hai, but then along with lymphocytes, you will notice that the sugar is less. In the question that I discussed with you, it was normal. And then the protein in this case would be grams. TB में protein grams में होगा. Cobweb coagulum तो है, but protein will be in grams. The pressure would be elevated, and the color can be straw, it can be cloudy. I mean, color will obviously not help in identification, but then TB meningitis is usually when he will say HIV positive patient, he will say a malnourished child. Those are the situations which would help you, and more importantly, it will be a long history in a patient. But for viral meningitis, the aspect is viral meningitis and viral encephalitis findings will be same. यहाँ पे भी like there can be 25 to 100 lymphocytes present, but it is the sugar values that are normal, the proteins are elevated, and as far as the color is considered, that would usually be clear. But then in viral meningitis, there would be nuchal rigidity, and in viral encephalitis, there is no nuchal rigidity present in a patient. तो ये तो baseline है. This is the baseline information that you guys are anyway familiar with. What I wanted you to be aware is that there can be permutation combinations of the same as well that need to be basically practiced. Chalo. So given you a slight introduction with respect to sugar values be normal. Yeah, bache, sugar will be normal na in viral meningitis. Okay. Next is acute ischemic stroke. मुझे cause बता देना. Yeah, it's a dense MCA sign that can be present. Why are we getting this acute ischemic stroke? What you can see in this case is that a very classical dense MCA sign. Apart from the dense MCA sign, you will ultimately be having is a very clear-cut hypodensity that would be occurring, but that hypodensity will take about 6 hours to appear in a patient. Yeah. The leading cause of acute ischemic stroke would be answered as NVAF, that is non-valvular atrial fibrillation is the leading cause why this could be occurring. Yeah, it's an infarct basically, but like the clot occurred because there was like a embolus in the left atrial appendage that went into the brain of the patient. So the case presentation would be having that dense MCA sign, phase deviation, arm weakness for a couple of hours. If he says what is the investigational choice, your answer would be a non-contrast CT head only. He can then say what is the best one for early detection. Your answer is a diffusion weighted MRI. And in case the CT head is normal, and he says what is the next best investigation, especially if he says CT scan is normal and he says what is the next best investigation. You guys can comment in the chat box. Yes guys, CT had normal in a chap where acute ischemic stroke presentation is there. What is the next best investigation to be done? Okay, fine. MRI में तो time लगता है ना. MRI sequences are gonna take some time. So what we will do in this particular case is, अगर CT scan normal है, भाई पेशेंट का रिलेटिव तो पूछेगा ना आपसे कि डॉक्टर साहब आप तो कह रहे हो सीटी स्कैन नॉर्मल है और हमारे पिताजी को आप कह रहे हो कि ब्रेन स्ट्रोक हो गया है, तो आपको कैसे पता आप में दिव्य दृष्टि है क्या, राइट? मोस्ट पेशेंट्स नाउडेज, आई मीन आजकल तो लड़ाइयाँ होती है, यू सी ना डॉक्टर बीटिंग अप अ पेशेंट, पेशेंट बीटिंग अप डॉक्टर. तो आई मीन इफ सीटी स्कैन इज नॉर्मल आप फंस जाओगे ना. तो यू हैव टू बी सेइंग, यू हैव टू लाइक बी प्रिसाइज. तो आप क्या बोलोगे? What would you say is that you would be doing is a CT angiography. Yes guys, it is a CT angiography. That is what we say in Hindi is a Rangeen CT scan, and this CT angiography can help you identify at least a LVO, that is a large vessel occlusion, and once you pick up that LVO, that is a large vessel occlusion, then we can use medicines to destroy the clot which is occluding the middle cerebral artery of the patient. So window period for management of acute ischemic stroke, everybody knows this is going to be 4.5 hours. Ideally, if he says upper limit, तो फिर आप 6 घंटे बोल देना, because we want to extend the benefit to up to 6 hours. And कई questions में तो इतना कुछ पूछेगा ही नहीं भाई, वो सीधा बोलेगा भाई what is the top most priority of acute stroke consultation, तो ABC आंसर करना, where A would be securing the airway of the patient. I mean, how would you secure the airway? Is like जुबान पीछे को गिर रही है and the person's tongue can basically occlude the airway, so we can put in like a Goodell's airway, and this Goodell's airway can help in preventing the tongue from falling backwards. B is not for breathing. B is not for breathing in this case. Normally तो ABC में airway breathing circulation होता है ना, stroke management में breathing मत बोलना है यहाँ पे. Then here it is the blood pressure value. The cutoff to be remembered is more than 185 by 110. If the blood pressure is elevated तो हम thrombolyze नहीं करेंगे, because one of the biggest side effects of thrombolysis is bleeding. So if the blood pressure is elevated, we will lower the blood pressure by using labetalol or nicardipine. And first we have to lower the BP, lowering the BP. I mean, if the cutoff is this, then thrombolysis, that is L-Teplis, is absolutely contraindicated. And C would be clearly establish the time. C is not circulation. C is clearly establish the time the patient was last seen normal. So A is airway, B is blood pressure value for the cutoff of thrombolysis, and C is clearly established the time seen normal. Then we use an online calculator, that is National Institute of Health Stroke Scale. This is to be sure that doctor is not mistaking the diagnosis or making a mistake in the diagnosis of stroke. Clinically, I know I'm dealing with the stroke, but I just want to be double sure. So in an online calculator, we feed in the values with respect to the reflexes and the neurological deficits that you're seeing. You do a complete neurological examination. There's a complete checklist in the drop-down menu. And if the value turns out to be more than 5, it's stroke. Now, what will you do? Either you are gonna go ahead with endovascular endovascular therapy, or you're gonna go ahead with thrombolysis in a patient. Endovascular therapy means we do cerebral angiography and we catch the clot in the brain and take it out in one piece. So either of the two would be done, and the threshold for EVT would be answered as 6 to 24 hours. So now we can treat stroke up to, answer is 24 hours. And if it says thrombolysis, then I think you guys have already done that fact in the comments that it's an upper limit of 6 hours. But if he specifically says ideally, then the answer would be given as 6 hours. Yeah, storm is a contraindication to thrombolysis. That's definitely on. Bleeding diathesis must always be remembered. Endovascular therapy is also called as mechanical thrombectomy. Perfecto. What is wake up stroke? कोई अगर सुबह सुबह जागा और उसको स्ट्रोक के फीचर है तो उसको वेकअप स्ट्रोक बोलते हैं ना. तो अर्लियर वी नेवर यूज टू ट्रीट वेकअप स्ट्रोक, बट नाउ वी कैन, बेसिकली बिकॉज वी हैव डिफ्यूजन वेटेड MRIs and we can use those sequences to estimate the time of onset of stroke. So now wake-up stroke is being treated. Earlier, like there was no treatment. Only if person woke up, was okay, and then he had stroke, we used to say कि भाई इसको stroke. I mean, the concept was if somebody woke up with stroke, he may be outside the window period of thrombolysis 6 hours. Like somebody slept at 10 o'clock in the night. He could have had a stroke at 11 in the night, but he woke up at 8 with the face deviation, arm weakness and everything. So he's beyond the 6 hour period. No? So earlier we used to like say no thrombolysis for persons with wake-up stroke, but now we can treat everybody up to 24 hours. So I mean that's like I would say a blessing in disguise. Okay, fine. So enough about stroke. We next talk about epilepsy. This was a PYQ where he talked about a patient of GTCS and he has been having seizures for fairly longer duration. So you guys can comment here regarding the drug of choice for management of this GTCS patient with seizures which are lasting for more than 5 minutes. हाँ जी हाँ जी हाँ जी हाँ जी यहाँ पे आंसर सोडियम वैल्पोरेट नहीं है ना. दिस इज GCSC in a patient, so you will say that I will be giving IV lorazepam for management of this patient. Lorazepam के साथ में second क्या drug होगा? Very good. Diazepam can be given, lorazepam can be given. Yeah, the answer is not sodium valproate here because GTCS तो है but उसको अभी तो GCSC हो गया ना. That is why the question mentioned कि उसको 5 मिनट से ज़्यादा सीजर चल रहे हैं. So we will give lorazepam and phenytoin. Phenytoin is that sodium channel blocker. It will stabilize the excitability of the neurons. तो पहले lorazepam and phenytoin देते हैं and that should help in control of these episodes, and then we will gradually restart sodium valproate in this person. But at the moment the question is about GCSC where we will have to give lorazepam and phenytoin drip for this patient. The drug of choice for focal seizures would be carbamazepine. This molecule can contribute to affecting the white blood cell count, so agranulocytosis. Agranulocytosis can be a side effect that could be asked with respect to carbamazepine. So this is one of the drugs, though we can be using even lamotrigine for these patients or even oxcarbazepine or phenytoin for focal seizures, but usually it is carbamazepine that would be the single best answer, or oxcarbazepine that would be used. Great, yeah, and hyponatremia, yes. So hyponatremia and agranulocytosis are two side effects that are asked. Fine, atonic seizures, drug of choice, please. In atonic seizures, unlike GTCS, the tone will become lesser. Like in GTCS, there's a tonus followed by clonus. Here, the drugs would be. No, it is not ethosuximide for this one. Na? The drug would be sodium valproate only. In दोनों का ही आंसर valproate है ना. Atonic seizure and myoclonic seizure, it is always gonna be sodium valproate. The only exception for this entry is if he says myoclonic seizures involving the trunk, like if he says infant, and then he says myoclonic spasms, that would be involving the trunk of the patient, that is salam seizure. I mean, I should not have said the word salam seizure because that makes it super easy for you. But then if he says myoclonus involving the trunk, then it is salam seizures where ACTH would be used or vigabatrin would be used. But otherwise for myoclonic seizures, your answer would be given as sodium valproate only. For GTCS, it is obviously sodium valproate, but if he specifically mentions female in the reproductive age group, then I'll not give sodium valproate. Then either I can be using lamotrigine or I can be using is levetiracetam. Between the two, levetiracetam is written first in the book, so we'll go with this. It will also cause neural tube defects. The incidence would be lesser. Quick comments in the chat box. What is the best drug for prevention of febrile seizures? Options are oral diazepam, rectal diazepam. Oral diazepam and rectal diazepam for prevention. You have to comment oral versus rectal. Okay. For prevention of febrile seizures, it is oral diazepam that would be used here. No, it is not rectal diazepam. It is for prevention. It is oral diazepam that is to be used. We also have to use paracetamol in the patient to control the fever, but that's not going to be preventing it because even low-grade fever can be having it. So he specifically asked for like, how do you prevent it? Answer is oral diazepam. Yeah, clobazam is a good answer, Nikhil. But we're just making it simple for everybody who can participate for this one. So for prevention, it is oral diazepam and clobazam can be used. Nikhil, perfect. Irfan, you are perfectly right for this one. Yeah. And for the ongoing episode, it is like rectal diazepam, or we can go for a intranasal midazolam in this patient also. So perfectly okay. Otherwise, it is like for the treatment part, if the episode is there, rectal diazepam can be used in the patient, though it's gonna be a little messy and unhygienic as well. And if it is absent seizures, then it is ethosuximide that would be used for these patients. Okay, so this list is pretty straightforward for the epilepsy part, so I don't think so it will contribute to any issues. You can quickly comment with respect to the commonest type of epilepsy that is found in children. Like in adults, the commonest type of epilepsy is GTCS. It is usually caused by neurocysticercosis. GTCS, and yeah, it could be a focal seizure with a secondary generalization. Most of the time, like person may not have a GTCS full. It can be like a focal seizure followed by a secondary generalization. So that's why like carbamazepine would have been used. Yeah, the commonest type of epilepsy in children would be answered as no febrile नहीं होता. It is answered as Rolandic epilepsy. Rolandic area जो होता है that is motor area of the brain. So the most common epilepsy in children would be answered as Rolandic epilepsy. Yeah, it is a focal seizure that would be occurring. Exactly. No, no. If the question says what is the most common type of seizures in children, then your answer is given as febrile seizures. But if he says the word epilepsy, then your answer would be given as Rolandic epilepsy. And if he says what is the most common cause of epilepsy in adults in India, most common cause of acquired, though I think I have already said it, but still the most common cause of acquired epilepsy in adults, he's asking the cause of GTCS. I mean, why would a person be having a generalized tonic-clonic seizure? Yeah, that would be the tape. Yeah, this is gonna be neurocysticercosis. This is the poor tapeworm that can contribute to these manifestations. So what we talked about is a couple of CNS aspects. Let's have a look at myasthenia gravis as well. Myasthenia gravis will always be having D features. They would be like a diplopia, they would be diurnal variation. He'll always say the symptoms of the patient will tend to increase in the evening hours. Unlike in Lambert-Eaton syndrome, where the symptoms will improve by evening hours, here he will say that the weakness of the patient will become terrible in evening hours. Then there would be weakness of the vocal cords, there would be weakness of the diaphragm, and most importantly, this condition has muscle weakness with normal deep tendon reflexes. This again has no parallel in medical science, because normally whenever we read about weakness, there is absent reflexes or brisk reflexes. But here it is going to be a muscle weakness with normal deep tendon reflexes in a patient, and the D features can there be present here. So yes, guys, like since the D features are very classical for this one, diplopia, diurnal variation, dysarthria, dyspnea, normal reflexes, so diagnosis would be spot on. And again, the depolarization, no, like you said, why can't we use fluoroquinolone? So again, the side effect is that the depolarization of the neuromuscular junction is already defective, and fluoroquinolones interfere with that. So there would be like an increased prolonged weakness in this patient. Yes, the question will say either a young male, a young female, or he will talk about a young female, or he'll begin with a male more than 50 years of age with all the D features as I've explained. And in last time's FMG exam, the question said investigation choice. Good. Some people have answered screening also. I'm waiting for your answers. Screening test is not a tensilon test. It is the ICE-PAC test. Yeah, it is a ICE-PAC test. That is a screening test. He has asked about investigational choice last winter. So the best test for diagnosis in this condition would be a single fiber electromyography that will be showing the report of a jitter. It is single fiber electromyography. If this is not in the options, your answer would be given as repetitive nerve stimulation. And for repetitive nerve stimulation, the findings that would be seen, it would be called as a decremental response. So for the topic of myasthenia gravis, what you need to be very sure is that ICE-PAC test for screening. Yeah, both in low frequency and high frequency nickel, it would be decremental response. Lambert-Eaton में उल्टा होता है ना, Lambert-Eaton syndrome, like I was discussing this in the NEET PG discussion yesterday, that in Lambert-Eaton syndrome, low frequency will be having a decremental response, and high frequency will have an incremental, but for myasthenia gravis, everywhere it is a low frequency there. No, that is for confirmation. जो पल्स 1 में क्वेश्चन था वो ये था कि आइसपैक टेस्ट के बाद में अगला टेस्ट क्या करते हैं. तो आइसपैक टेस्ट के बाद में जो अगला टेस्ट करते हैं, दैट इज दैट एंटीबॉडी to confirm, that is anti-acetylcholine receptor blocking antibody. So first test that we do in the patient is ICE-PAC test. Then we do a antibody, that is the anti-acetylcholine receptor antibody. So in the last time's pulse test, I had basically spoken regarding this anti-acetylcholine receptor antibody test. And then another test that is done is anti-musk followed by single fiber electromyography. So that would be the sequence there. And tensilon test is done in difficult to diagnose cases in case yeah, it is a specific ना, तो ये sensitive हो गया ना. The first we go for a sensitive test, then we go for a specific test for confirmation, and then overall like the test which has a very high sensitivity and a specificity and is practical also is a single fiber electromyography. No, tensilon test is done अगर ये सब कुछ negative हो ना. ISPAC test is inconclusive, antibody test is negative, anti-acetylcholine receptor antibody negative, musk antibody negative, SFEMG inconclusive, rapid nerve stimulation inconclusive. अगर ये सारे के सारे टेस्ट इनकंक्लूसिव आ रहे हैं तो फिर आप क्या करोगे, फिर तो आपको स्टैंडर्ड करना ही पड़ेगा ना. दैट इज गोना बी टेंसिलॉन टेस्ट इन अ पेशेंट. सो इट सेज टेंसिलॉन टेस्ट एक बैकअप है. इट इज लाइक अ टेस्ट. जब बाकी सब फेल हो जाते हैं तो टेंसिलॉन टेस्ट करते हैं. इस पे योर क्वेरी वुड भी अगर बाकी सब फेल हो जाते तब इसको करते तो वाई इट इज नॉट द नंबर वन टेस्ट. कोई साइड इफेक्ट है ना कॉलिनर्जिक क्राइसिस का. The biggest side effect with tensilon is a possible risk of a cholinergic crisis that can be triggered. So it is a very, very good test where you have the ptosis coming up and then there's a white tearing effect when you push hydrophonium. But then it's like a last resort. हाँ वो वैसे वाला ही जैसे अभी हम last resort revision कर रहे हैं तो वो last resort वाला कि भाई चलो nothing else is working तो भाई focus तो कर रहे हैं ना, तो we're trying to remember things there. Yeah. Treatment for generalized variety of myasthenia gravis would be a thymectomy. Thymectomy is not curative in this condition. That is one. It is not that we'll be cured of the disease process. It's not. It's just that the medicines की जो requirement होती है वो कम हो जाती है. And then we'll be using pyridostigmine for these patients, and along with that, we'll also be using steroids. Or if there is like toxicity with steroids, we might be using immunomodulator drugs like mycophenolate or azathioprine for management of these patients. But if he specifically says ocular myasthenia gravis, then for ocular myasthenia gravis, we don't need to go for thymectomy. बोलता है इतने बड़े ऑपरेशन की जरूरत ही नहीं है. I mean, you don't need to go for a thymectomy for ocular myasthenia gravis. It is steroids and a pyridostigmine that can be used here, though we can have a paradoxical response to pyridostigmine where they can be worsening in the patient as well. But thymectomy is not recommended for the ocular variety of myasthenia gravis where symptoms would be pretty stable in a patient. ओके जी, गुलियन-बारे सिंड्रोम के लिए तो स्टैंडर्ड ही कॉजेज हैं. इट वुड बी कैम्पाइलोबैक्टर जजनाई. Then he can ask you about the viruses, that is Zika virus. Yeah, this was I think last time's question ना कि क्या टेस्ट करेगा. ऐसे नहीं था which is the most question था कि anti like person has been subjected to ISPAC test. अब अगला टेस्ट क्या करेंगे. So that is gonna be the anti-acetylcholine antibody. Yeah, it is Zika virus. Campylobacter jejuni is initial, then Zika virus, hepatitis E virus, to name a few, are the reasons why this could be contributing to it, even E. coli. And then after this, there would be type 2 hypersensitivity. And then he has also asked, like from the physiology perspective, that in this case, there would be a demyelination. So the demyelination is not on the spinal cord. The demyelination in Guillain-Barre syndrome is in the peripheral nervous system. The demyelination is in the peripheral nerves in this patient. The demyelination in this condition is in the nerve roots which are coming out of the spinal cord. So he said यहाँ पे कौन-कौन से nerve fibers involved होते हैं. So it is the large nerve fibers that would be involved. That is like the A delta or the A gamma fibers that would be involved here. Yeah, last time's paper, he said like in GBS, which nerve fibers are involved. So we have like type B fibers, type C fibers, and then we have A alpha, A gamma. So it is the big nerve fibers that would be involved in this condition. And another question was regarding this myasthenia gravis, that which are the receptors which are going to be blocked here. So it is not muscarinic receptors, obviously, because we are talking about the neuromuscular junction. So the receptors which are going to be affected in this condition by the antibodies are the nicotinic receptors that would be affected. So it is nicotinic receptors that are involved in myasthenia gravis at the NMJ. That was the baseline question. And for Guillain-Barre syndrome, it is peripheral nerves that would be involved. Yeah, postsynaptic is okay. Postsynaptic is perfectly fine. You have to comment in the chat box with respect to demyelination part. If you are having demyelination of the spinal cord, what is the disease called as? Demyelination of the spinal cord is called as. The hint is in this condition, anti-aquaporin 4 antibodies would be present. Yeah, AIDP is acute inflammatory. That's one of the varieties that are present. Yeah, demyelination of the spinal cord due to anti-aquaporin 4 antibodies. Yeah, one condition where we can be having it is subacute combined demyelination, which is due to vitamin B12 deficiency. Another condition where we can be having it is like neuromyelitis optica, right? That is Devick's disease, where astrocytopathy would be occurring. So NMO, neuromyelitis optica, SSAD due to nutrition, where the demyelination spinal cord can be involved. But in GBS, it is like peripheral nerves and the nerve roots that would be involved. Now, the criteria that are used for diagnosis are called as Brighton criteria. They would be ascending symmetrical flaccid paralysis. The paralysis will start from the bottom and will be going upwards. But a lot of these questions, he would like to focus on the bilateral flaccid paralysis in this patient. He might say, what is the earliest feature in GBS? Then the earliest is the loss of ankle jerks would be the first one, then knee jerk, and like that. The reflexes in the upper limbs will also get involved. So the earliest manifestation would be loss of bilateral ankle jerks, which would be written in a question as distal areflexia as the earliest manifestation in GBS. Then is bilateral loss of knee jerks in a person, then even like biceps jerk, triceps jerks would be affected. That's what I meant by the word Brighton criteria. So FAME is the word here. F is the flaccid paralysis. A is the absent reflexes. M is the monophasic illness, which can be very fast over 12 hours, that the guy might actually develop a diaphragmatic weakness. In fact, if he says what is the cause of death in patients of GBS, it is a diaphragmatic illness that would be seen here. Diaphragmatic weakness or diaphragmatic paralysis is the reason why these patients can die. Then is another finding which is present with A, albuminocytological dissociation. So I can use alphabet A 2 times, absent reflexes, and albuminocytological dissociation. And E is for electrodiagnostic studies. What are the electrodiagnostic studies done here? That is nerve conduction velocity. That would be showing a demyelination or axonal damage, which is consistent with Guillain-Barre syndrome. So FAME is a mnemonic that helps us to remember the Brighton criteria for diagnosis of this condition, where alphabet A is coming in the discussion 2 times, absent reflexes and albuminocytological dissociation. The main treatment for this condition, okay, Nikhil, I'll come to you. For the treatment of this condition, we have to answer as intravenous immunoglobulins. Now, when to answer transverse myelitis is the question that has come up. So I'll just give you pointers for transverse myelitis. One of the highlights of transverse myelitis will be that there will always be a very characteristic sensory level given in the question. What I mean by a sensory level is the question will say that patient is saying like below his umbilicus, he feels as if somebody has tied a metal wire around his body and is tightening the metal wire around the legs of the patient, and the metal wire is burning into his skin. So sensory level would mean that there would be a particular level, like at umbilicus, above umbilicus, somewhere at some like particular dermatomal level, there would be below that, there would be extreme lancinating pain. Lancinating pain would mean like somebody has taken a piece of glass and is cutting his skin, or somebody has taken a military grade barbed wire and is tightening the wire into his body, or somebody is pouring acid over his skin. That is like the lancinating pain. That's kind of description. Predominant sensory level would be given in transverse myelitis. In Guillain-Barre syndrome, we usually have bladder and bowel sparing. Now, because sparing is there, so I did not mention it in the description. But when it comes to transverse myelitis, there is a predominant bladder and a bowel involvement that is occurring in this case. And then transverse myelitis initially will present with spinal shock, where all reflexes in the patient would be lost. But then subsequently, like in the legs, there would be a Babinski sign coming up. So transverse myelitis is an inflammation of the spinal cord for which we have to give methylprednisolone. Everything changes. For GBS हम steroids नहीं देते हैं. For GBS हम steroid नहीं देते हैं. ट्रांसवर्स माइलाइटिस में लांसनेट मोटर फीचर तो होंगे, मोटर फीचर तो दोनों में ही होंगे. वीकनेस है, स्पाइनल शॉक मैंने लिखा तो वीकनेस वुड बी अ फीचर इन बोथ ऑफ देम. But then bladder and bowel involvement, lancinating pain described in a question, then it is transverse myelitis, and here MRI will be helping in determining the inflammation of the spinal cord as well. Okay, ji. So, okay, so the size wise, it is the PCOM that will rupture. If he says which is the common blood vessel that is likely to rupture, then it is PCOM. And where it is written ACOM, it is like ACOM is the more common site that is present. So there are two different things. One is the common site of berry and one is more prone to rupture. Okay जी, fine. पीकॉम के चांसेस रप्चर के ज़्यादा होते हैं, मोस्ट कॉमन इन एकॉम. हाँ जी, और थर्ड नर पैल्सी होती है. चलो जी, आई थिंक वी आर सॉर्टेड फॉर ब्राइटन क्राइटेरिया इन द ट्रीटमेंट पार्ट फॉर दिस कंडीशन. एंड व्हाट वी डू नेक्स्ट इज द कट ऑफ्स फॉर दिस कंडीशन. कॉन्ट्राइंडिकेशंस ऑफ माइस्थेनिया ग्रेविस, आई थिंक कुछ और पूछना चाहते थे आप ना. लैम्बर्ट-ईटन का डिफरेंशियल पूछ रहे होगे ना. लैम्बर्ट-ईटन में तो मतलब टोटली डिफरेंट बॉल गेम हो जाएगा. Yeah, plasmapheresis can be used in the patient of I mean in place of intravenous immunoglobulins for this condition. I can be using another approach, that is plasmapheresis with an equal efficacy. But then this would require like more support also. चलो आपने बोला ही plasmapheresis, तो बताओ मुझे which blood group would be called as a universal plasma donor? Since you said plasmapheresis, तो relative से लेना पड़ेगा ना. So universal plasma donor. हाँ जी, हाँ जी. Universal plasma donor would be AB in this case. Yeah. Universal plasma donor would be AB. Great. Yeah. वही ओ तो फिर जो ब्लड वाला होता है ना, वो क्वेश्चन वही था कि ब्लड का डोनर हो जाएगा या प्लाज्मा वाला डोनर हो जाएगा. तो प्लाज्मा डोनर वुड बी AB इन द पेशेंट. चलो जी, ओके. सो आई विल मेंशन द डेटा हेयर. फास्टिंग तो आपको पता ही है 100 से कम है. इफ अ पर्सन इज हैविंग फास्टिंग बिटवीन 100 to 125, 120 आ रहा है, तो द टेक्निकल वर्ड यू विल यूज इज, वेटिंग फॉर योर आंसर्स. सपोज द वैल्यू एट 75 ग्राम ग्लूकोज इज बिटवीन 140 to 199. व्हाट इज द टेक्निकल वर्ड? और ये जो 2 घंटे के बाद सैंपल लेते हैं, इसको बोलते क्या है? वी आर टेकन अ फास्टिंग ब्लड सैंपल, देन आफ्टर 2 hours वी आर टेकिंग अ सेकेंड वैल्यू. या मिलर फिशर सिंड्रोम इज सेम लाइक जीपीएस? नो, मिलर फिशर में तो यार देयर वुड बी अ थर्ड नर्व पैल्सी, नॉट अ सिक्स्थ नर्व पैल्सी. somebody mentioned about MFS, तो मैं बोल देता हूँ उसको यहाँ पे. Somebody mentioned regarding Miller-Fisher syndrome. So Miller-Fisher syndrome is OAA, that is ophthalmoplegia, and then there is areflexia. Though I don't think so he'll get into this. उसको पूछने के लिए जब GBS है तो वो Miller-Fisher नहीं पूछेगा. But if it does ask you this, then ophthalmoplegia, then it is areflexia, and it is ataxia that is present. Or Miller-Fisher syndrome, that is where you would be having is a third nerve palsy in the patient. Right. Different set of antibodies here called as anti-GQ1 antibodies. Yeah, Millard-Gubler is sixth nerve, I think. Yes, you had picked it up very well. हाँ जी, ये 2 घंटे वाले को पोस्ट प्रैंडियल नहीं बोलते ना यार, वो तो है ही है ना. दिस वैल्यू इज कॉल्ड एज 2 hour वैल्यू. बहुत बार ये समझा दिया मैंने, इसको पोस्ट प्रैंडियल नहीं बोलते हैं. ये जो 2 घंटे बाद वाली वैल्यू होती है, इसको हम 2 hour वैल्यू बोलते हैं. एंड देन द सैम्पल विच इज टेकन हेयर, दिस वुड बी कॉल्ड एज इम्पेयर्ड फास्टिंग ग्लूकोज, and this is gonna be impaired glucose tolerance. So IFG is impaired fasting glucose, the second one is impaired glucose tolerance, and this is gonna be anyway diabetes mellitus from the values that I've highlighted. Can random blood sugar be used for diagnosis of diabetes? Quick answers please. Can random blood sugar, this is a oral glucose tolerance test that we are talking about. 75 gram of glucose have been given to the patient. Can random blood sugar be used for diagnosis of diabetes? Yeah, not alone. Yes, with symptoms. Your answer is right. If it is the value of random blood sugar is more than 200 and there is presence of classic symptoms like there's a polyuria, there is a polydipsia, there's a weight loss that is present, then we can use random blood sugar for diagnosis of diabetes mellitus as well. Now, one of the common complications that we get with type 1 diabetes is diabetic ketoacidosis. So I'll give you a case-based scenario where he'll begin by describing a patient where the pH of the patient will be less, the bicarbonate values will also be low, the ketones will be there, random blood sugar will be. Please help me out for diabetes ketoacidosis. Yeah, HbA1c is one of the best tests for diagnosis of diabetes. That is okay. चलो, अब आपने HbA1c बोला है, मैं चाहता नहीं था उसमें हम जाएं, बट what is the number one reason for false elevation of HbA1c? पेशेंट का ब्लड शुगर नॉर्मल है लेकिन HbA1c का वैल्यू 6.5 आ रहा है. पेशेंट इज लिटिल वरीड लिटल क्या बहुत वरीड ही सेइंग सर मेरा तो ब्लड शुगर नॉर्मल आ रहा है, रैंडम भी और 2 घंटे बाद वाला भी, बट मेरा HB1C जो बढ़ा हुआ आता है. It can be like 5.7, 5.8. Normal is 5.6, so it can be impaired glucose tolerance or pre-diabetic range. It can be in diabetic range also. What is the leading cause of false elevation of HB1C? Yeah, CGM can also be done to determine complications of hypoglycemia. My question is totally अलग अभी. HB1C बढ़ा हुआ आ रहा है पेशेंट का, non-diabetic patient, like fasting blood sugar 2-hour values are normal, HB1C is elevated like 5.7, 5.8. Yeah, anemia. It is iron deficiency anemia, which can cause a false elevation, especially in Indian patients. Now, coming back to the question for diagnosis of diabetic ketoacidosis. For diagnosis of diabetic ketoacidosis, random blood sugar कितने से ज़्यादा होना चाहिए? For diagnosis of diabetic ketoacidosis, RBS in the patient should be more than how much? Yeah, it should be more than 250. The serum lactate in the patient is normal. Yeah, it is more than 250. So you will say diabetic ketoacidosis in a patient. In all these questions for diabetic ketoacidosis, do evaluate for whether the patient is in circulatory failure. If the patient is not in circulatory failure but is having evidence of dehydration, that is okay. If the person is in circulatory failure and he says, what will you do first for the patient? Then your answer will be that I will be giving a saline bolus to this patient. If the person is pulses are thready, then it is a saline bolus at 20 ml per kg till the pulses will come back in the patient. And then you will move on to the same treatment only, that once the shock has been treated, once the shock of the patient has been treated, then you will be giving a saline drip to this patient. So it is like a saline drip, and after saline drip, it is like a insulin drip after 1 hour. The only thing is in the question, whenever attempting a question on diabetic ketoacidosis, do check if there is any evidence of patient in circulatory failure, where he'll mention the word thready pulses or blood pressure is going to be outrageously low. Then you will say saline bolus followed by saline drip and then insulin drip. The standard treatment in the patient would be started. There is no role of soda bicarbonate for management of diabetic ketoacidosis. That is one. Can you give soda bicarbonate? Then the answer is a yes. Only when will you give soda bicarbonate? Then the universal rule is if the pH is less than 6.9 or equal to 6.9, only then soda bicarbonate is given. There is no rule of soda bicarbonate in routine management of diabetic ketoacidosis. Only rarely will you be using it, and the rare uses when the pH is less than 6.9. And then to the bottle of normal saline, you should be adding potassium chloride. This potassium chloride that will be added is 40 millicoulomb per liter. The values in the question can be falsely normal also, because acidosis causes potassium to come out of the cells into the blood. So potassium can be falsely normal also, but it will fall when you will give the insulin drip to the patient. So that's why, like, to prevent the fall that is occurring when you give insulin drip, you give KCl 40 milligrams per liter in advance to the management of this patient as well. So I think this is perfectly fine for DKA. I'll just change the situation as they've done in the paper. I'll use a different color to highlight it. The pH of the blood is 7.4. Bicarbonate is 24. Ketones are, let me say, 1 plus, or let me increase it. Ketones are 2 plus. Blood sugar of the patient is very high. Let me say going up to 800, and serum lactate in the patient is normal. Can I have the answers, please? Yeah, redistribution. Yeah, blood sugar is ultra high, so this would be a hyperglycemic hyperosmolar coma. This is hyperglycemic hyperosmolar coma, where again the fluid of choice would be normal saline in a patient. Why are ketones present in this case? Why are ketones present in this case? Why can ketones be 2 plus or 3 plus in this one? Ketones क्यों बड़े होते हैं? Ketones इसलिए बड़े होते हैं क्योंकि patient nil orally ना, because patient is इन कोमा. सो अगर पेशेंट कुछ नहीं खाएगा तो बॉडी में फैट की बर्निंग होगी ना, and therefore hyperglycemic hyperosmolar coma, where can be having ketones also present. The reason is the patient has not eaten anything. Starvation, as you are right, is perfectly fine. Next is a question in which the pH of the patient is 7.2. Bicarbonate is, let me say, 20 ketones in the patient are absent. The random blood sugar of this patient is, let me make it 250 only. थोड़ा diabetic है तो बढ़ी हुई है, and lactate serum lactate is elevated. Diagnosis बोल देना. Though the urine ketones in the patient are absent, there is still an acidosis present. I think I made it very simple for you. Yeah, this would be lactic acidosis. The correct answer for this one is lactic acidosis, which could be due to use of metformin in a person where the estimated GFR of the patient is significantly low. Very good, guys. I mean, you keep up the comments there. Perfecto answers coming up for lactic acidosis. And then I'll mention the last entry for this one. The last entry is like pH is okay, bicarb is okay, ketones are negative, random blood sugar is only 40, lactate is normal. So because the blood sugar of the patient is very low, so this would be a simple hypoglycemia that I've currently mentioned here before you. So I need to give 25 to 50% dextrose for management of this patient. But all of them that are described before you are unconscious, unresponsive diabetic patient permutation combinations that they've given in the exam. And among the 4 combinations that I've told, the most important one is the first one, which is to be remembered. Okay. First line management of diabetic ketoacidosis is always going to be normal saline. Should you answer a bolus or should you answer a drip is based on the volume status of a patient. Like if he says himself the word thready pulse, then it is a bolus. If the pulse is palpable, the blood pressure is at least, I can say, recordable. If the blood pressure is recordable, I'm not saying elevated, recordable, then we'll say a drip in a patient. To the bottle of normal saline, KCl should always be added to prevent the fall of potassium. The same thing is normal saline also, but yeah, the fluid will change. I mean, the fluid that if the blood sugar will go less than 250, then we might have to use 5% dextrose in the patient also. So the second fluid that can be used in the patient is like subsequently 5% dextrose needed to be added once the random blood sugar of the patient starts going to less than 250. That is when we might have to deal with hypoglycemia in the patient as well. Okay, what is the first line management of Addisonian crisis? Addisonian crisis question will always mention hypotension with hypoglycemia. I had one answer already, hypotension, hypoglycemia. What drug would you be giving in this patient? Yeah, I need to go ahead and give a shot of hydrocortisone. This is a distributive shock, so given fluids alone in this patient would not be really beneficial. Yeah, spironolactone is the answer here. Like if he will give you regarding Conn syndrome, and he says what drug would you give for preoperative stabilization, then it is spironolactone. Help me out with the investigational choice for Conn syndrome. Help me out with the investigational choice for Conn syndrome, and in similar sense help me out with the investigation for pheochromocytoma as well. Yes guys, drug of choice for Conn syndrome. Quick answers please. Okay, the test we'll be using is what is called as a salt loading test, or I can rather improvise there and say the word saline infusion test. Normally you can suppress the aldosterone production, but if it's the saline infusion test, then the infusion will be failing. For pheochromocytoma, the investigational choice that will be answering is a plasma free metanephrine levels. I would supplement that with a 24-hour. Yeah, it is a plasma free metanephrine and not a CT abdomen. Plasma free metanephrine, and then we'll go ahead with that gallium 68. Yeah, not fractionated metanephrine, it is free metanephrine that would be used here. And gallium 68 dotatate PET CT scan is the best way by which we'll be able to identify that there is a tumor. I mean, there's a biochemical evidence of the tumor, that is okay, but I need to have objective evidence. And the drug that we'll be using in this patient is phenoxybenzamine. And the second drug that we'll be using after phenoxybenzamine for these patients would be propranolol. As you are familiar, for management of this patient, the algorithm would be alpha plus beta blocker and not beta plus alpha. Yeah, thanks. Yeah, it would be, yeah, let it go. it would be alpha plus beta blocker that would be used for management of these patients. Okay, guys. PET CT is a good answer there. Cool. Fine. Moving to the next one. I have a question for you. This would be a smoker. He's also Mason by profession. Yes, phenoxybenzamine followed by propranolol is the correct answer. Yep. Okay, a smoker comes with complaints of shortness of breath and he's a Mason by profession. Pre and intraoperative. Yeah, this was a question that came nicardipine, no? Where we can use both pre and intraoperatively both, no? Mason मतलब मजदूर. Mason होता है construction worker, no? Mason by profession. By FEV1 FVC ratio of the patient is 0.8. So the answer in this case would be interstitial lung disease. So because the ratio COPD बोलने के लिए the timed vital capacity in the question should be FEV1 FVC ratio less than 0.7. So the point is we'll not go by cigarette smoking or we'll not go by construction worker. It is the FEV1 FVC ratio that will help in diagnosis in this patient. The answer to this particular question is option number B. Then is the next one where you can see a big if I say anything, the answer will become obvious. So yep, question on the screen at the moment. Obstructive, the value would be ratio is 0.7, no? 0.7. We take it at 70%. It's a better value as compared to 80%. FEV1, FVC, answer it as 0.7 and 0.8. Equal to 0.8 or more is restrictive and 0.7 or lesser is obstructive. Yeah, you can see a big clot in the pulmonary artery of the patient. So this is a CTPA, which is senior, and the investigation is a pulmonary thromboembolism. He has also asked what is the first investigation that would be done in this patient. Yeah, saddle embolus is shown. What is the first investigation? What is the investigation choice? How would you determine the etiology in this condition because there's a deep vein thrombosis? So all three have been questions of the previous years. Yeah, investigation choice is CTPA, CT pulmonary angiography. If he says what is the first investigation to be done, then it is a D-dimer assay. And if he says how do you determine the etiology of this condition, then for the etiology perspective, we'll go in for, yes guys, waiting for your answers for the etiology perspective. Perfecto. We'll go in for a duplex, that is a Doppler, that would help in identification. So, badhiya. Fat embolism syndrome will always follow GERD criteria. There would always be fracture of the long bone that would be given, and within 24 to 48 hours, there would be breathing difficulty or lungs there would be like these white spots of snowstorm appearance that would be coming. There can be a CNS involvement in the form of a coma, and most of the time the person will also be having petechiae. These petechiae would be appearing in the axilla and in the chest wall of the patient. So I've mentioned the major GERD criteria at the moment for fat embolism syndrome before you. Next is a patient with COPD. He's brought in with these crazy values of PCO2 of 60, and he says that what will be best done for management of this patient. So we'll go ahead with NIV, that is a non-invasive ventilation. The chap is having respiratory acidosis. The pH is less and PCO2 is elevated. So that will become like a PCO2 of the patient to be elevated. भाई मैंने क्वेश्चन तो डिस्कस ही नहीं किए कि हम तो थ्योरी पढ़ रहे हैं, ये तो आइसोलेटेड क्वेश्चंस थे. ओके, ऑर्गेनिज्म क्वेश्चन तो मैंने डिस्कस ही नहीं किया, मैं तो एक्चुअल टेस्ट वाले डिस्कस किए ना, जो सब कह रहे थे बड़ा आसान है, तो टर्न आउट टू बी डिफरेंट आंसर्स. Yeah, it's a type 2 respiratory failure. Exactly. You have a very good point there. The total of 4 types of respiratory failure. This is type 2, the standard one for COPD exacerbation. Okay, with a partial compensation, yep. Bicarbonate is elevated, so an interesting observation there. Organism specific approach to pneumonia is the next one to be understood. Alcoholism के लिए बोलते फटाफट से कमेंट करते जाओ यार, ठीक है. Community acquired pneumonia is gonna be pneumococcus, but वो tricky हो जाता है ना, theory तो वही रहने वाला है, it is just the tricky one ना, like I demonstrated before you, like it was looking like viral meningitis turned out to be encephalitis, तो थोड़ा बहुत coily होने किया लग रहा था हमें, turned out to be leukemia किया. Yeah, alcoholism would always be Klebsiella. ये alcoholic तो रोज आ जाता है, right? So I mean, whether it's cardiovascular or any other system, Klebsiella pneumonia will be the troublemaker. Ventilator associated pneumonia. Quick answers, please, guys. VAP in a patient. Klebsiella is perfectly sorted out. Ventilator associated pneumonia would be Staph aureus. नहीं, Pseudomonas होगा ना. The leading cause for ventilator associated pneumonia is Pseudomonas aeruginosa. Selective media बताओ. No, not Legionella. Just Pseudomonas aeruginosa, na? That would be gram-negative bacteria, polar flagellum. Colonies would be bright and shiny in character. And he'll say like, what is the culture media here? So we'll be using cetrimide agar. And then he'll say like, what is the drug of choice for Pseudomonas aeruginosa? I'm waiting for comments for the same. Some people said Staph aureus, that is for hospital-acquired pneumonia. No? Like when we're talking about nosocomial pneumonia, then it's going to be Staph aureus, which is to be taken into consideration, that cluster of grapes appearance. And this is where we'll be using linezolid for management. Though even in the MCQ, daptomycin would be given. Your first answer for this one would be given as linezolid. Yeah, we'll be giving meropenem, or we can be using piptaz, that is piperacillin with tazobactam for management of these patients. Then, no, aspergillus would only be coming up if there's an immunocompromised state, now where there's a sputum which is having that acute angle branching, only in those circumstances. Okay. So alcoholic with red colored jelly sputum, as we've discussed, is Klebsiella. The technical name for this would be a Friedlander's bacillus. No, we'll not give moxifloxacin for this patient. Moxifloxacin would be given only for a curve score that is elevated to be at least 2 or more than 2. This would be Friedlander's pneumonia once again, and there would be a lung abscess that can be occurring. So air fluid level can be described there. There could be air fluid level that could be described in both of them. In fact, if he says which of the following is more commonly a cause of lung abscess, then Staph aureus is more importantly a cause of lung abscess where air fluid level can be given. Overall, the most common cause of lung abscess is Staphylococcus aureus pneumonia. The radiological finding, which is the precursor to this, would be pneumatoceles, and these pneumatoceles will unite together to form then is a lung abscess. So both of them can result in like suppurative condition of lung abscess. और lung abscess से एक change आता है हमेशा nails में, that is clubbing. Clubbing को बनने में time लगता है, so we always read about like clubbing developing in like months altogether. But if he says the word fastest clubbing is seen in, if he says fastest clubbing is seen in, then that would be a case where fastest clubbing would be seen with respect to a case of a lung abscess. And that's again like two suppurative conditions where lung abscess would be developing. For COPD, the leading organism would be Haemophilus influenzae. That's why these patients should have taken a vaccination. And in comatose patient, it is microaspiration of saliva. So if he says drug abuse, comatose, then it is anaerobic organisms. Anaerobes per se in the saliva. Anaerobes would be like anaerobic streptococci in the saliva that could end up in the lungs, and that can cause an aspiration pneumonia in a patient. सो या ये तो नाम याद करने हैं यार, ये तो बड़ा सिंपल सा ही है, न्यूमोकोकस है, फिर सूडोमोनास, स्टैफ ऑरियस, क्लेप्सिला, देन एनारोबिक ऑर्गेनिजम्स फॉर दीज पेशेंट. न्यूमोनिक वगैरह के चक्कर में मत पड़ना. उससे you are right, like drug intoxication is occurring, so again there is a microaspiration that is occurring here. So there must be lung abscess that has occurred in the chap. Drug intoxication again would be anaerobic lung abscess in this case. Yeah. For Klebsiella, no, the initial treatment would be just using ceftriaxone, and along with that, we'll give ceftriaxone only for those patients. And empirical treatment with this ceftriaxone with azithromycin or doxycycline. Okay जी, anaerobes once again. चलो जी, नेक्स्ट जो है एड्स पेशेंट है, लो CD4 काउंट है विद बायलैटरल इन्फिल्ट्रेट्स एंड ओकेशनल क्रेपिटेशंस प्रेजेंट. And because infiltrates are given, yeah, the treatment here is clindamycin. Good answer there for treatment for clindamycin. चलो जी, अब आपके लिए जो क्वेश्चन है वो है कि ये जो पर्सन है जिसमें आपको क्रस्ट पिंग पोंग बॉल अपीयरेंस दिख रहा है इन द गमोरीमिथामिन स्टेन. What drug should be given for prevention of this infection? Treatment नहीं, cotrimoxazole तो treatment हो गया, prevention बता देना. This is a crushed ping pong ball appearance that you are familiar. The stain which is present here is called as a gummorymethamine stain. The diagnosis in this patient is pneumocystis jirovecii pneumonia. मुझे यहाँ पे tests बताने हैं apart from the stain that can be done. I mean, obviously I'll be doing a sputum gram stain which will turn out to be showing no organisms. Then on the sputum I can be doing a gummorymethamine stain which is already been discussed. But any blood test that can be done in this patient for diagnosis of this invasive fungal infection. IFI होता है invasive fungal infection. So any blood test that can be done. Yeah. For prevention it is oral cotrimoxazole. और इसको कब तक देना होता है? जब तक the CD4 count of the patient will be more than 200 for 3 consecutive months. अगर इसका CD4 count बढ़ जाता है then it is cool. Otherwise we will have to continue cotrimoxazole. For the treatment of this condition also we will be using cotrimoxazole, but he has asked for the prevention perspective, and the blood test that we do in these patients for invasive fungal infection would be beta D glucan test. Beta 1,3 glucan. The blood test that we'll do is a beta 1,3 glucan that can help in identification of this invasive fungal test that is caused by pneumocystis jirovecii pneumonia. Though overall, if he says in an AIDS patient, overall the most common cause of pneumonia, then don't answer jirovecii. Overall, if he says most common cause of pneumonia, galactomannan for aspergillus. Esophageal candida is not helpful in diagnosis of AIDS. Now it can be seen, esophageal candida can be seen, or oropharyngeal. In fact, oropharyngeal candida is never diagnostic. Esophageal can be seen even with inhaled corticosteroids. Yes, overall most common cause for pneumonia would be answered as pneumococcus, where he will mention about lobar pneumonia. If you read a question that says lobar pneumonia with AIDS, then it is pneumococcus which is to be answered. Legionella is on a ship cruise, and this is usually associated with SIADH, syndrome of inappropriate ADH secretion. Legionella is one bacteria which can both cause typical एज वेल एज एटिपिकल. बाकी सारे जो होते हैं वो या तो टिपिकल निमोनिया बोलते हैं या एटिपिकल बोलते हैं. इसको एटिपिकल इससे बोल रहे हैं ना, इसमें इलेक्ट्रोलाइट इम्बैलेंस हो जाएगा. सो SIADH कैन अकर, बट इट इज वन विच कैन कॉज लोबार निमोनिया ऑल्सो, और लोबार के साथ साथ में इट कैन कॉज अ एटिपिकल निमोनिया एज वेल. सो द मेन मैसेज इज, आई मीन व्हेन यू रीड अबाउट टिपिकल एटिपिकल, दोनों कर सकता है. द क्वेश्चन विल से विच बैक्टीरिया कैन कॉज बोथ टिपिकल एंड एटिपिकल निमोनिया. टिपिकल वुड मीन दैट देयर वुड बी अ कंसोलिडेशन इन द लंग, जिसके ऊपर ब्रोंकियल ब्रीदिंग आ जाता है. And atypical pneumonia would mean that they would be like bilateral infiltrates that would be present in both the lung fields of this patient and would be diffusely present. So both presentations can be there, but Legionella can be associated with hyponatremia. So there was one question in the paper where like the sodium values were given to be lesser and person had seizures due to electrolyte imbalance, which is again very atypical because normally pneumonia patients have seizures due to hypoxia, but here it is the electrolyte imbalance that would be responsible. And for Legionella pneumophila, like the antibiotic that would be used is macrolides again, that is azithromycin would be used for management. They will also ask you CURB 65 score. I think everybody knows the parameters there. That is confusion, elevated blood urine nitrogen, then is gonna be respiratory rate, blood pressure, and age. The updated version is called as CRB 65. That means that we will still follow the same rating there. C is confusion, R is respiratory rate, which you will have to count in the question. It is more than 30. The blood pressure values would be less than 90/60, and then is the blood pressure of the patient. If it is less, that means that he's going probably into septic shock. And then you'll take into consideration age of the patient as well, more than 65 years. So the values between 0 to 1, then the antibiotics that you are most of the time using is amoxi, and along with that you'll be using is azithromycin, and in case there's a previous hospitalization, then we'll add clavulanic acid. But if he says the word 2, then the answer in your question will tend to change, and you'll be answering ceftriaxone with azithromycin. or instead of this you might be giving ampicillin with sulbactam with azithromycin. ये याद रख लेना कि एमसीक्यू में एजिथ्रोमाइसिन तो होना ही होना है, इट इज़ जस्ट दैट उसके साथ में क्या है। और क्योंकि इतने सारे एंटीबायोटिक देते हैं तो कई बार पेशेंट्स को इतने साइड इफेक्ट्स हो जाते हैं, लाइक सम पेशेंट्स आर नॉट एबल टू टॉलरेट सो मेनी हैवी ड्यूटी एंटीबायोटिक्स दैट यू आर गिविंग and they'll might end up with diarrhea even after oral antibiotics, IV antibiotics. So in those circumstances, what you will do here is you can put them on like levofloxacin or moxifloxacin. So it is just that whether you have to answer amoxi with azithromycin oral treatment or would you be answering intravenous is based on the curve 65 score for this patient. Okay, ji. Children is also pneumococcus, man. Yeah, that would be respiratory fluoroquinolones like levofloxacin, moxifloxacin, or gemifloxacin that can be given. Then is the case of pneumothorax where the classical thing in the question would be air entry will be absent. The question will mention breath sounds to be absent. और साथ में ब्लड प्रेशर क्रैश करना चाहिए. अगर बीपी क्रैश नहीं कर रहा है तो टेंशन न्यूमोथोरैक्स मत बोलना. देन योर आंसर वुड बी गिवन एज ट्रॉमेटिक न्यूमोथोरैक्स. एमसीक्यू में ट्रॉमेटिक न्यूमोथोरैक्स भी था और टेंशन न्यूमोथोरैक्स भी था. तो अगर तो ब्लड प्रेशर क्रैश करेगा, like a person sustained a trauma and after that the BP is crashing, then say tension pneumothorax in a patient. Otherwise, if the BP is recordable, then your answer would be given as traumatic pneumothorax for the person. In a large number of these questions, instead of like saying unrecordable BP, he may mention regarding mid-diastolic shift. Because if the heart will be displaced from its original position, it will contribute to kinking of the great veins. SVC and IVC of the patient will be kinked. So the word will be mediastinal shift. That tells you that SVC, IVC दब गया है, which is the cause of issues in this patient. Or he might just say prominent neck veins or elevated JVP. So ये वाली findings लिखी हो तो बोलना tension word, or for the absent air entry and breath sounds, it is going to be pneumothorax. And then you will answer like this for these patients. The first thing we will do is we will be putting a wide bore needle, but not all questions will be having a requirement of a wide bore needle. As a now question is on secondary pneumothorax, then we'll not put a wide bore needle in a patient. It's only for tension pneumothorax that this is to be answered. Fifth intercostal space anterior to the mid-axillary line, triangle of safety everywhere here. Then it's gonna be a intercostal drainage tube. That would again be put in the fifth intercostal space. Everything that we're doing is work with respect to the area of the triangle of the safety, and then this intercostal drainage tube will be connected to this bag that you can see inferiorly, that is called as a underwater seal drainage, that is a UWST, and this is the real big deal. Yeah, the needle decompression part would be the one that would be sorted. So I think this is pretty straightforward, guys, as far as working out the data for this one is concerned. Yeah, it is UWST, the underwater seal drainage that would be used. Okay. For pleural effusion, the main thing to be remembered is two things. One is gonna be transudative pleural effusion. The second one is an exudative one. So ख़त्म ही कर लेते हैं यार. अब तो ज़्यादा मतलब एग्ज़ाम जो होगा वो इतनी ही ड्यूरेशन का होगा. तो अब ये सोच लो कि अभी आप थक रहे हो, एग्ज़ाम में थकना नहीं है, राइट. चलो, गुड गाइस. ट्रांसुडेटिव का जो मोस्ट कॉमन कॉज है वो हार्ट फेलियर है. Or exudative could be either due to empyema, that could be a parapneumonic effusion. PP is a parapneumonic effusion, that would be empyema, or it could be due to TB, it could be due to lung cancer, or it can be a Dressler syndrome as well. Yeah, perfectly. Exudative malignancy, empyema for necrotic. Yeah, end of that GT was quite tiring. I understand exactly. That's what I'm trying to just say. चलो जी, तो मेनली वो बोलता है कि हम यहाँ पे कौन से वाले क्राइटेरिया यूज़ करते हैं. तो क्राइटेरिया का नाम लाइट्स क्राइटेरिया होता है. दीज लाइट्स क्राइटेरिया आर यूज टू डिफरेंशिएट ट्रांसुडेट वर्सेस एक्सुडेट. तो अगर ये वैल्यू मोर देन 0.5, मोर देन 0.6, मोर देन 2/3 होगी तो बोलना कि ये एक्सुडेट है. That is gonna be inflammatory. और अगर ये less है, then it is gonna be a transudative variety that we'll be using to differentiate. The leading cause of transudative is heart failure, and if it's a unilateral effusion with cachexia in a person, जहाँ पे help करने के लिए he can mention the word ट्रिपेप्निया, हाँ, ड्रेसलर सिंड्रोम में दोनों होता है ना, आज के मॉक टेस्ट में भी तो था ये क्वेश्चन. Dressler syndrome is post-MI pericarditis as well as pleuritis now, because pericardium is touching the pleura in some of the areas. So Dressler syndrome is a post-MI. If you attended the pulse test today, it was turning out to be the answer on the basis of exclusion. So Dressler is gonna be a post-MI pericarditis as well as a post-MI pleuritis as well. So both can be present. I hope that sorts out the issue. And if it's a massive pleural effusion in a patient और उसके साथ साथ में ट्रिपेप्निया भी present है, then it would be a malignancy that is to be considered. That would be a malignant pleural effusion. मतलब lung cancer की बात हो रही. It is a malignant pleural effusion where the lung cancer would be present. Okay. Fine guys, unilateral massive effusion cachexia, then you would be able to differentiate or identify the aspects here. So चलो कोई कमेंट्स कर देना, डायग्नोसिस बोल दो यार. यहाँ पे ये स्ट्रेट लाइन है, यहाँ पे एलिस कर्व है. So if the Ellis curve is present here, then I'll be saying that the person Ellis curve would be for pleural effusion in a patient, that is hydrothorax. And then there's a straight line that is present, so that will tell me that this would be a hydropneumothorax. So the image on the right hand side is basically a hydropneumothorax. Cool. Because it's a straight line, the water level would be not following the concavity. Great. First Ellis curve wala hydrothorax, and the second one is a hydropneumothorax. Chalo ji. Moving on to a couple of questions next. Child develops a diarrhea with dehydration. I'm almost coming down to the last few units here, pretty easy ones there. Diarrhea with dehydration tha, that's the trigger, no? Hypovolemia is present. And then the urine output is down to 50 ml, blood pressure is elevated with the anasarca. Yes, guys. Some guys have already picked up the key hint that is given in this question. That would help you analyze this. I'm waiting for more people. Yes, the main hint in this question is left-sided kidney is enlarged. ये किसी और में नहीं होता ना, बाकी सब में किडनी का साइज चेंज नहीं होता है. इफ में अगर बेसिकली आपको ये समझना है कि बाकी जितने भी रीनल फेलियर होते हैं उनमें किडनी का साइज एनलार्ज नहीं होता है. ओनली वन वेयर द किडनी साइज वुड बी एनलार्ज वुड बी रीनल वेन थ्रोम्बोसिस इन अ पेशेंट. सो गुड पिकअप गाइस, गुड पिकअप. आई मीन जितने भी रीनल फेलियर वाले केसेस होते हैं सब में किडनी का साइज नॉर्मल होता है, सिर्फ एक में बड़ा होगा आरबीटी के केस में. Next is a question that came in last time's FMGE exam. How to differentiate acute kidney injury from chronic kidney injury? Yeah, thrombosis due to dehydration. Yeah, Salman, you're right. Thrombosis was occurring due to dehydration. That would contribute to this. Hanji, hanji. Exactly. Chronic kidney disease के लिए एक तो हम estimated glomerular filtration rate calculate करते हैं. Then we check for urine albumin ना. Albumin के grades बनाते हैं. That is urinary albumin. Mark my words, there serum albumin नहीं है. इसको mix up नहीं कर लेना, because in some apps they have mentioned serum albumin and creatinine clearance. फिर आपका आंसर चेंज हो जाएगा. Then it is gonna be, I mean, it is not serum albumin that is being used. It is urinary albumin that is being used. Urine output तो will always be less, no? Urine output will always be less, and size of kidney is normal in diabetic nephropathy. I think this is like last time's paper that I said. CKD के लिए हम EGFR कैलकुलेट करते हैं और यूरिन एल्ब्यूमिन क्रिएटिनिन रेशो चेक करते हैं. So in urine albumin creatinine ratio, like we give albuminuria as A1, A2 and A3, so that helps in identification of the damage in the kidney of the patient. So I think we are sorted for the second question there. The next one is hearing loss है. इसमें polyuria था, failure to thrive था. Then he was like literally wasting our time, because if you would be having salt wasting, then there would be hyperaldosteronism that will cause metabolic alkalosis with hypokalemia. So some guys just read metabolic alkalosis with hypokalemia and answered it as Conn syndrome, but Conn syndrome में तो BP बढ़ा हुआ होगा, यहाँ पे BP कम है. So this is not a case of Conn syndrome. Conn syndrome will have hypertension. यहाँ पे hypertension नहीं है. Dense disease will be having increased calcium in the urine, so you would be having like increased chances of kidney stones. तो जो बच गया वो बार्टर और जेटलमैन syndrome है. And between the two, the key thing to be remembered is the hearing loss that is present. क्योंकि जो किडनी में क्लोराइड चैनल डिफेक्टिव होता है वही इनर ईयर में भी प्रेजेंट होता है हेयर सेल्स के साथ में, विच इज डिफेक्टिव इन बार्टर सिंड्रोम. सो द आंसर हेयर इज ए बिकॉज ऑफ द फैक्ट दैट हियरिंग लॉस इज गिवन. If that hearing loss is not given, then it will go more in favor of Gentleman syndrome in a patient. But if the hearing loss is present, then it is like a Bartter syndrome as the first answer. Yeah, sensory neural hearing loss only with respect to Bartter syndrome. Okay. Next is a question on electrical burns, and he has mentioned that there is red color urine that is present. I mentioned the answer already here because there is a myoglobinuria which is occurring in this patient. I just wanted to bring to your attention that myoglobinuria is normally crush injury. So normally it is like a truck going over the legs of a person, car crash that you are thinking, but even electrical burns can result in myoglobinuria in a patient, and that can cause increased urinary creatinine ratio in a patient. Great. फाइन जी. नेक्स्ट इज नेफ्रोटिक्स. तो नेफ्रोटिक के आपको सारे फीचर्स तो पता ही हैं. हाइपो एल्ब्यूमिनीमिया, देयर वुड बी मैसिव प्रोटीनूरिया एंड एडिमा. वो कॉजेज प्रैक्टिस करने. एडल्ट का बोल दीजिए फटाफट से. मैसिव प्रोटीनूरिया इज डिफाइंड एज मोर देन 3.5 grams in a 24-hour period. For nephrotic syndrome, what is the leading cause that you would be answering for adult? ये भी थक गया क्या? Okay. Yeah, 3.5. What is the leading cause in adults case? हाँ जी, हाँ जी. The leading cause in adults would be focal segmental glomerulosclerosis. Yeah, congenital nephrotic syndrome in children, that is the Finnish variety. This is the Finnish variety of nephrotic syndrome that would be seen with respect to children. This is minimal chain disease, MCD. This would be minimal chain disease. Cool. So, fine. We have worked out the data here. मुझे electron microscopy बता दो for focal segmental glomerulosclerosis. I'll be writing the electron microscopy of minimal chain disease, that is loss of food processes or podocytes. Loss of food processes or podocytes is a feature with respect to MCD in a patient. Let me know the electron microscopy finding for focal segmental glomerulosclerosis. बोलो बोलो भाई. Effacement of the podocytes. Great. Loss of food processes of the podocytes. The same finding can be seen even with respect to focal segmental glomerulosclerosis. So differentiation is made on the basis of light microscopy. लाइट माइक्रोस्कोपी मिनिमल चेन डिजीज में नॉर्मल होती है, और फोकल सेगमेंटल में देर वुड बी लाइक फोकल डिपॉजिट्स और देर वुड बी सॉलिडिफिकेशन ऑफ द टफ्ट. So if you get a question in which food processes or podocytes are lost, it can be either of the two possibilities. If light microscopy is normal, then you will answer as minimal chain disease. And if he says light microscopy में effacement के साथ साथ में electron microscopy की finding के साथ में solidification of the tuft that is given, then you will answer as focal segmental glomerulosclerosis. Yeah, for prednisolone, minimal chain disease is steroid responsive nephrotic, so we would be using it. बढ़िया जी. So geriatric age group it is MGN, membranous glomerulopathy, where usually we have is anti-phospholipase A2 antibody. This is anti-PLA2R receptor antibody here. Electron microscopy finding बोल दो इसकी जरा, MGN की. Electron microscopy finding for membranous glomerulopathy. Light microscopy, दोनों ही बोल दो, light microscopy, electron microscopy, no? Yeah, the spike and dome is more specific for light microscopy. Now that light microscopy causes that spike and dome appearance. And as far as the electron microscopy is concerned, he will say electron dense subepithelial deposits. It is spike and dome, and then is that electron dense subepithelial deposits that would be present in this case. Yep. Fine, guys. The next one is anyway very easy. The starry sky kidney that you can pick up. That starry sky appearance is always a feature that is seen with PSGN, that is post streptococcal glomerulonephritis, which would be a type 3 hypersensitivity reaction. And what you can also notice is the hypercellular glomerulus which is present in this case. The presentation will be mainly that of hematuria, because the capillaries of the glomerulus are damaged, along with that there is hypertension. और नहीं इसमें C3 लेस होता है ना, नेफ्राइटिक सिंड्रोम में हमेशा C3 लेस होता है. C3 इज नॉर्मल ओनली फॉर नेफ्रोटिक सिंड्रोम, नेफ्राइटिक में तो हमेशा कम होता है. एंड देन मोर इम्पॉर्टेंटली लाइक यहाँ पे भी प्रोटीनूरिया दिया होगा, दैट वुड बी 1 to 3 grams पर डे. हो सकता है कि क्वेश्चन में स्टार्टिंग में वो मेंशन कर दे कि पर्सन इज ऑल्सो हैविंग प्रोटीनूरिया डॉक्यूमेंटेड, बट प्रोटीनूरिया तो दोनों में आएगा ना, बिकॉज दे वुड बी बोथ, बिकॉज द मैग्नीट्यूड ऑफ प्रोटीनूरिया इज डिफरेंट. Value देख लेना. I mean, by on reading the word proteinuria, a lot of guys they tend to get biased and they tend to go towards answering it as nephrotic, but वहाँ पे तो value फिर अलग हो जाएगा ना. So in this particular case, it is like a subnephrotic proteinuria with hypertension with hematuria that would be present. So yeah, anti-DNS antibody would help in identification of this condition. चलो जी फटाफट से यहाँ पे आंसर्स बोलते जाओ. We are doing the last unit here for today. ASO नहीं बोलना बच्चे, आपने ASO नहीं बोलना है, दैट इज फॉर रोमैटिक फीवर. यहाँ पे एचलाजिया कार्डिया इज द प्रेजेंटेशन, और इसका कॉज उसने पूछा था, लाइक ही डिड नॉट से डायग्नोसिस क्या है, ही सेड इसका कॉज क्या है. They can be sore throats, they can be skin infection. Achalasia cardia, the bird-beak appearance is present. What is the cause for this condition? Quick answers, please. अरे नहीं यार, इसका आंसर होगा ऑटोइम्यूनिटी. द लीडिंग कॉज फॉर एचएलएसए कार्डिया इज ऑटोइम्यून डैमेज टू द ऑयरबैक प्लेक्सस, और उसकी वजह से जो ए पेरिस्टालसिस होता है. चागस इज नॉट द मोस्ट कॉमन कॉज, इट इज ऑटोइम्यूनिटी. चागस नहीं भाई, चागस तो साउथ अमेरिका में ना, हम इंडिया में बैठे हैं. सो द मोस्ट कॉमन कॉज इज ऑटोइम्यूनिटी फॉर दिस वन. देन इज ऑब्वियसली द zinker diverticulum which you can pick up very easily, that is a pulsion diverticulum. The next one is a filling defect, which is an irregular filling defect because there would be cauliflower growth present. So what we are thinking in this case can be a cancer of the esophagus. It's a carcinoma esophagus that I'm thinking of. Investigational choice बोल दो. He gave this image. He says इसका investigational choice क्या होगा? Lung cancer can also be a cause. Yes, filling defect. What is the investigational choice for this? Yes, guys. Great. Upper G endoscopy. It is endoscopy with biopsy that would be useful for diagnosis of this condition. Though in the options, like there was no mention of any biopsy word, but endoscopy is the main thing that will be useful for diagnosis. There is a diffuse esophageal spasm where you can pick up the classical finding of a corkscrew esophagus. This condition will be managed